everybody. I'd like to welcome you all to the 2019 Journal Symposium, What's New in the Old. We're going to talk about geriatrics today, which happens to be one of my favorite topics. As most of you know, I'm Deb Cully. I'm an anesthesiologist at the Brigham and Women's Hospital in Boston. And here is my colleague, Amanda Fox from UT Northwestern. Did I get that right?
Southwestern.
Southwestern. Well, it was pretty close. We are going to be graced with the presence of a number of really wonderful speakers and a number of great abstracts that have things to do with our geriatric surgical patients. Our first speaker is somebody that I met a number of years ago when I was a very young and very inexperienced scientist. Dr. Rosenthal is an amazing woman. She's the professor of surgery at Yale University School of Medicine. She's on her 21st year as chief of surgery at the VA Connecticut healthcare system and serves as the chief surgical consultant for VA New England and has done so since 2008. She's an active general surgeon with a special interest in the surgical care of the older surgical patient. Currently, she's also a co-PI on the Coalition for Quality in Geriatric Surgery grant with Dr. Clifford Coe, Director of Quality Programs for ACS. Through her 4-year national grant funded through the John A. Hartford Foundation, she's worked with 60 stakeholders to develop a set of standards for surgical care of older patients, which has culminated in the creation of the ACS Geriatric Surgery Verification Program. She's been involved with the ACS Geriatric Surgery Program since 1995, has served as vice chair, then chair of the ACS Geriatric Surgery Task Force since its inception in 2004. She recently co-chaired the panel to develop the ACS National Surgery Quality Improvement Project. We know of that as NSQIP, the American Geriatric Society Best Practice Guidelines for the Optimal Preoperative Assessment of the Geriatric Patient. And last year, she completed the follow-up perioperative management guidelines. She's also currently co-director of the ACS NSQIP Geriatric Pilot Project, a collaborative of 23 hospitals across the US and Canada. She's also been actively involved in the American Geriatric Society, JHF, Geriatrics for Specialists Initiative, which is where I met her when I received one of the first Janigan scholarships that led to what is now becoming a very successful career. So with all of that said, I'd like for you to invite me in welcoming Dr. Rosenthal to the podium for her lecture.
Thanks so much, Deb, and it's really nice to be here. You know, I'm a surgeon, and to be in an audience with anesthesiologists is a novel experience for me because it's hard enough for me to get one of my own anesthesiologists to listen to me, so I'm really happy, and I have a lot to say, which I'll talk about. So it's a pleasure to be here. I've learned a lot already. So I do have 2 disclosures. The first one is I get a small grant, is this hissing to other people?
Is it hissing to you out there?
No.
Thank you.
Okay. I get a small honorarium from the Coalition for Quality in Geriatric Surgery grant, but more importantly, I have a Medicare card. And whatever I tell you is really for my own self-interest. And having had surgery, I can tell you I'm not concerned about the surgeons. It's really the anesthesia that I'm concerned about. So we all know patients are aging. It's not a surprise to us. We know that starting in 2012, 10,000 people get a Medicare card every day or are eligible for a Medicare card every day. By 2030, 1 in 5 will be over the age of 65, but this is the number that really gets me. By the time the residents in the audience get to be sort of at the point where they're winding down in their career or beginning to burn out a little, there'll be nearly 20 million people over the age of 85. More than 50% of persons over 65 have some surgical procedure in the remainder of their life, and the 15% of the population who's currently over the age of 65 account for 40% of the operations, or 19 million. So we're going to have a lot of older patients that we need to take care of. Now, when we talk about geriatric surgery or issues in caring for older adult surgical patients, the word that really is the important word is variability. And there's variability certainly in the physiologic of aging, the physiology of aging, and people who age successfully can be robust and have lots of resources, and we're not concerned when they need surgery and anesthesia because we think they'll do well. But for people who don't age so successfully, like the frail elderly, their reserves are just being used to maintain homeostasis, and we worry about them doing well as well. But there's not just variability in the physiology, there's variability in the outcomes for surgery. Just checking where those are. There's variability in the outcomes of surgery depending on what hospital you go to. So this study looked at the mortality for a variety of operations, and you can see for almost all these operations, the dark bars are the hospitals that perform in the lowest 20th percentile, and the light bars are those that perform in the highest 20th percentile. And you're twice as likely to die if you were in one of the low-performing hospitals than you are if you're in a higher-performing hospital. So there's great variability. But there's also variability in the way care is provided across the country, and so it also depends on where you may live. And so this was from a study that looked at surgery in the last year of life for people who died in 2008. And you can see that almost 32% of patients have surgery in the last year, and almost 18% in the last month, and 8% in the last week. But that's not what is astounding to me, is that there's such huge variability. If you live in Indiana, in Gary, Indiana, that's 34% will have surgery, and if you live in Hawaii, it's only 11%. Now, people have looked at whether people in Hawaii feel differently about end-of-life care, and there really is no difference. And so it's really just what's available to you about what surgery you get. And so if you look, you say, well, Indiana and Hawaii are very far apart, but I want to sort of hone in, oops, let me go back one. I want to just hone into this little area of New York, and then I want to just tell you a story about this person. So this is Dr. Michael Katz. He's an 89-year-old pediatrician. He was actively working part-time. He's an academic pediatrician, was the chair at Columbia for 13 years. And he was on one of his many trips at age 89, coming home from Auckland, and he didn't feel well. And so he got off the plane, he managed to get home, he passed out at home, and he was taken to a local hospital, which was one of the big academic medical centers in New York, where he was found to have endocarditis of his mitral and his tricuspid valve. And he was treated. He was quite sick for quite a while, but he had severe damage to both of his heart valves. And his doctor said to him, well, we'll put you on palliative care and we'll send you home, and you'll live at home for about 6 months, and that'll be it. And his wife said, well, why can't he have surgery? And they said, oh, no, surgery is not an option for you. But because she had contacts and she knew medical people around New York, she went to another major medical center 2 miles away, where they did what she called cardiac boot camp. They did prehab, they gave him nutrition, they gave him exercise, and then they operate on him. And the reason I know about Dr. Katz is because when our geriatrics program was covered in the New York Times, he contacted us and he said, I'd like to tell my story if you want to hear it. And he came to our meeting, our quality and safety meeting in July, and he told the audience about what his experience had been like. And the thing that bothered him the most was nobody had asked him about how he would feel about risking his life by having big surgery with a high mortality rate, or whether he would be happy just living the 6 months at home. And he clearly, the way he put it was, if they looked at my frequent flyer miles, they'd know I would rather die in surgery than sit at home, unable to get out of bed for the next 6 months. So even in that 2-mile difference in New York, the options for this patient were very, very different. And we really need to see what we can do to kind of standardize the care for older surgical patients. So the American College of Surgeons, with its partners, the American Geriatric Society and the John A. Hartford Foundation, but also with partners of the ASA and many others who I'll talk about, have put together many several different projects to try to help improve surgical care for older adults. So we have the guidelines, the pre-op guidelines, and the peri-op guidelines that were introduced in 2012 and 2016. We have sorry, I just can't see so well. We have the database. We have a NISQIP database for geriatrics and a recent calculator. But most importantly, we have the Coalition for Quality in Geriatric Surgery, which I'm going to tell you about, and how that's led to our geriatric surgery verification program. So these are the guidelines, and they've been around for a while. They've been pretty well written. There's a pre-op checklist, and there are perioperative guidelines with a rounding checklist. But these guidelines really do emphasize three major things. There's goals and decision-making, maintenance of function, cognition, and maintenance of nutrition and hydration. But it's when you think about sort of helping Dr. Katz make his decision, we don't really have good data about what is important to older patients. We can tell them if they're going to die, we can tell them if they're going to get a wound infection, if they're going to get pneumonia, but we can't tell them if they're going to get delirium, and we can't tell them if they're going to have a functional decline, and that isn't part of our usual language. So we need some kind of decision tool to help us tell older patients what this impact might be. So the American College of Surgeons has the National Surgery Quality Improvement Program risk calculator. This is the surgery risk calculator. Have any of you seen this? Do you know what this is? So you put in the kind of operation the patient's having by CPT code and some characteristics of the patient, and then you get the complications that the patients may have, like pneumonia and other things like that. But there is nothing in that database that are the important things for older adults, like function, cognition, delirium, and functional decline. And so in 2014, we put together a consortium of 23 hospitals that added to the NSQIP risk calculator several different variables. Some were pre-op variables and some were outcome variables in the four areas of, I have geriatric eyes here, so it's not so good. In the 4 areas of healthcare goals, function, cognition, mobility, and then the 30-day variables of function at 30 days. And what we were able to do is we were able to put together a risk calculator that looked at patient risk factors of living situation, that's nursing home, living at home, fall history, use of mobility aids, use of having cognitive impairment, having a surrogate signed consent and palliative care from admission. And entering those, we were able to look at the outcome variables of postoperative delirium, functional decline, new mobility aid use, and pressure ulcers. So this risk calculator gives us a little bit of an idea about what we tell patients about what their chance of having delirium and functional decline can be. It also allows us, because this is a database that has very good input in terms of what the complications are, it also allows us to tell a hospital, and these are our hospitals that were in this consortium, it lets us actually benchmark against the standard for those hospitals. So this is an odds ratio of functional decline and delirium, and you can see that each hospital has an odds ratio, whether they're better or worse than the average, and the ones on the left are better and the ones on the right are worse. So this is the first time we had a way of actually benchmarking functional decline and delirium so that hospitals can put an initiative in place and see if that initiative really does improve things. So now we had some guidelines and we had some data to collect, but how can we tell Dr. Katz and his wife what's a good hospital to go to? How would they know? And so we decided that we needed to have a real geriatric surgery verification program like the trauma programs and the bariatric programs and the cancer programs that have about in them 3,000 total hospitals across the country. And the basic principles of these quality programs are you need to set the standards, you need to define the infrastructure, you need to see what kind of data you want to collect, and then you need to have a third party come in, like Joint Commission, and say, you are meeting those standards, and the public can be confident that that hospital is meeting those standards. So we approached, the American College of Surgeons approached the John A. Hartford Foundation, and we asked for funding, and the vision was to create a set of standards and a program that actually would improve care for older adults. We gathered 60 stakeholders, and I highlighted here that the ASA was one of our big stakeholders in this effort. But our stakeholders were really not just medical people. We included patients and families, and then we included healthcare professionals and medical specialists, and we also included insurers and regulators and also people who were healthcare advocates, like AARP was one of our stakeholders and CMS was one of our stakeholders, the American Hospital Association. And we got them all together. We had a stakeholder meeting in September of 2015, And we met to actually map the current state of care for older adults and then see what we needed to do and to set as the priorities for achieving what we thought we needed to do. And so these were the themes that emerged. There was poor alignment of patient care with patients, the care the patients actually got, and we need to focus much more on eliciting patient goals, like Dr. Katz's goals. There's no specific geriatric-specific pre-op assessment. There's no data on patient-centered outcomes, like how did the patient feel about the surgery for older adults. And there's little counseling for patients about those outcomes because there's little education on the part of the providers about them. There's also a lack of a coordination and poor transitions, and there's a lack of financial support, and we really need to align the payers and the reimbursement so that there is an incentive to actually improve the care. We also made visits to 11 hospitals across the country to see how it was really happening in the field. And we realized that everybody shared the opinion that the older patients were different and something needed to be done, but nobody knew what that was, or it was completely variable what that was. And variability was the word. Some places had delirium programs, some places had no quality programs at all. And what was most astounding was that there were really silos. And I realized that just at this meeting, I was listening to the work that you're all doing on brain health, and I'm thinking, you're just across the ether screen for us, and we don't really know this. We don't really know about this work. And so we really need to break down those silos. So we put all this together, all the literature, all the guidelines, all the visits and everything, and we came up with 308 preliminary standards. And the way we took these standards and made sure they were valid and feasible was we sent them to these 60 stakeholders, and they did this sort of RAND methodology, modified Delphi, where they review the stakeholders review the standards once at home and then review it a second time in a group. And when I saw that there were 308 we finally came up with, I said, they're never going to come. They're never going to send this back. But we got almost close to 100%. There were one or two who didn't. But they sent back these standards, and everybody said that they were all valid, but some weren't that feasible. And so we used that information, and we said, okay, 308 standards will never make it. And so we honed them down, we put some of them together, and we came up with 92. We then sent those 92 to 1,500 hospitals around the country on paper, and we said, which ones are you doing already? And if you're not doing them, how difficult would they be to do? And we used that information that we got back to come down to 33 standards. That's an order of magnitude lower, which was great. We then took those 33 standards, and we tested them in 8 hospitals. We sent the standards to the hospital, we had everybody do them, and then we got feedback from them about what worked and what didn't. And we finally came to our final set of 30 standards. And what was most important was to make these standards doable so that everybody doesn't think it's a huge burden without losing the effectiveness of doing them. So those were our standards. And so we then took these standards and we put them into this geriatric surgical verification program that focused on patients' goals. It focused on standarding pre-op evaluation, both for decision-making and for addressing vulnerabilities, protocolized interdisciplinary care so that patients got protocolized care, and it improved transitions, not just transitions in and out of the hospital, but transitions even within the hospital. And these are our standards. We've joined the other groups of standards from the American College of Surgeons. There are 9 chapters, which is the usual format now for these chapters. And I just want to spend a couple of minutes talking about some of the things in Chapter 5, which is the patient care and expectations chapter, just so you can get a sense of what those were. So this is the first section, which is goals and decision making. And the discussion is to be about overall treatment goals, goal status, identifying a medical proxy, and then talking about life-sustaining treatment for people who are going to be in the ICU, and reaffirming decision-making. Like older patients say that often they don't hear very well what the decision was in the first meeting, and they want to be able to have an opportunity to have a second meeting, and that's also part of the standards. But the real key to the standard is how the surgeon has the discussion with the patient about what might actually happen, what the expectation should be. And so we added this sentence that's underlined in red, which says the anticipated impact of both surgical and non-surgical treatments on symptoms, function, burden of care, living situation, and survival. And so those things about living situation, function, and burden of care are something that we don't often talk about. And then we said we want to be sure that that's documented in the chart. Now, we wanted to be careful that people don't just make this a checklist and say, yes, we had this, or put a smart phrase into EPIC. We really want to invest in training people how to have these discussions so that Dr. Katz would have had the right discussion with his caregivers, with his care team. The next section is about the preoperative workup. We have geriatric vulnerability screens, and once we have a positive screen, a management plan for that screen. We have an interdisciplinary pre-op conference so that we can say what we need to do for older patients. Do they really need that surgery with geriatric input? And we have the surgeon and the PCP confer about whether or not the patient should have the surgery. And so these are the screens: over 85, impaired cognition, delirium, impaired function, impaired mobility, nutrition, difficulty swallowing, and a palliative care screen. And I just want to talk about two of them just briefly. So this is data from our own database, that geriatric pilot database, and preoperative cognitive impairment is associated with a high risk of delirium, but also a high risk of new mobility aid and functional decline. And we know that delirium, and this is also from this study, we know that patients who get delirious, they also have higher mortality, more complications, and much more frequent discharge to non-home locations. And what's worrisome about this and what's important about this is that the estimated cost of each of these delirium episodes is between $16,000 and $24,000. So that's a potential of $38 to $152 billion burden. So when Dr. Adams today talked about all these initiatives for young people, and we really didn't mention how much the cost of caring for older patients is if we aren't careful and if we don't figure out how to do it right. Because this would be a huge amount of money to invest in some of those other programs like smoking cessation and gun violence. And so also, how difficult is it for us to screen for cognition? The mini-cog test is a 3-item recall and a clocks. It takes 2 minutes. And I was disappointed to hear yesterday that Dr. Dina was talking about a survey she did, and in her survey, only 82.6% of anesthesiologists, you who know so much about brain health and delirium, only 82.6% of you, rather 82.6% of you do not do a cognitive screen preoperatively. And it takes just a couple of minutes. It's not really a big burden. And the other thing is pre-op mobility screens. So patients with fall history or who use pre-op mobility aids, they have a very high chance of also having functional decline or delirium. And so it's also important to do a functional screen. And it's really easy to do a functional screen. There's something called the timed up and go, where you sit patient in the chair and you mark 10 feet, you have them walk 10 feet, turn around and sit back down and see if it takes them more than 15 seconds. And you get a lot of information about whether that patient is going to be able to get up out of bed right after the surgery, if they're going to need a lot of assistance, or what you're going to need to do to make sure they don't get fall and get harmed. And the last section I want to talk about is the postoperative management, which is how we sort of protocolize care postoperatively. We want to return sensory equipment. We want to look for inpatient medications. We'll talk about the Beers drug for 1 minute. Most importantly for you all is the opioid-sparing multimodality pain medication. And we think that that plan should be made right up front when we first meet the patient and individualized for that patient. Then there's standardized postoperative care, interdisciplinary care, revisiting goals of care for patients in the ICU, and then at discharge that we actually inform the patients and their family of what to expect in terms of some of the geriatric syndromes, like patients might be at high risk of fall or they might have delirium, and to educate them on that. So these are easy things to do, returning glasses and hearing aids. You know, my administrative officer has a very soft voice. And when she talks, I say yes a lot of time because I can't hear her. And sometimes I say yes to things that I shouldn't be saying yes to. So you really, if you expect cooperation from a patient or understanding, they really need to have their hearing aids and their glasses. It's pretty simple. Also, there are these drugs, the Beers drugs. How many of you know the Beers drugs? Okay, so these are drugs that are potentially harmful in older patients and can cause delirium, and the American Geriatric Society has just updated them. Several hospitals have in their pharmacy packages from their EMRs, they identify these drugs so that people are careful. There's benzos and Benadryl, but many other drugs you might not think of. Then again, there's the opioid-sparing modalities, pain modalities. How many people do planning for postoperative pain management in multimodality, individualized to patients? Good, well that's good. That's good to see. And then finally, there's the systematized care postoperatively. How many people do ERAS? Well, that's good too. So the postoperative and the intraoperative pieces of ERAS can apply, and there's the organization called NICH, which is Nursing and Care of Hospitalized Elderly. They also have standardized protocols, so there are plenty of different opportunities to actually help put these protocols in place. So these are the standards for the Geriatric Surgery Verification Program and how we got to be where it is. The program standards were released in July so that people could get familiar with them, and then next week we'll actually be releasing them for application for places to join. And what we've found from this whole experience is that it really does take a team from all the different specialties in order to care for older adults. It's, of course, the patients at the center, but it has to involve the family and the caregivers. It has to involve the healthcare team, but all of us, and we have to break down our silos. Cuthert from the Deaconess said to me before, when I said, I'm a surgeon here with anesthesiologists, it feels a little weird. He said, oh, I could put up an ether screen for you. So, I mean, we really have to take those down. We work in the same room, and we really have to sort of get rid of those silos. And finally, we have to advocate for our patients with the hospital systems and the hospitals, and we have to convince them that it's within their best interest. And there is a huge return on investment to caring for older patients in the appropriate way. So we'd like you to all join us. The program will take applications starting in October, and if you could bring it back to your hospitals, that would be great. Okay. Thank you. We're taking questions now, or?
Thank you very much for that introduction to all the good things that you've been working on with the coalition and the standards. I think for the sake of time, what might be best is if I have you sit down there, we bring up Dr. Brown, and then if you can come up at the end of his lecture, we'll do questions for both of our expert speakers. The way this is going to work today is we're going to have two speakers, content experts related to geriatrics in anesthesia. And then we have 11 outstanding abstracts that were submitted this year to go through for the following 2 hours with questions after each abstract. So to make time for that, I'm going to be speedy in my introductions, but we are fortunate to also have Dr. Charles Brown here today. He's an associate professor of anesthesiology at Johns Hopkins. He also trained in emergency medicine as well, and for about the past 10 years has been doing really high-end research related to preservation of brain health in the perioperative setting in a multitude of different areas related to delirium and cognitive decline. So I want to introduce Dr. Brown and hear what he has to tell us today. Thank you.
Great. So thank you, Drs. Fox and Cully, for the kind invitation to talk today. Okay. So my disclosure, so I'm funded by the NIH-NIA, which I'm very grateful for a Beeson Award. I've had a data share with Medtronic that's complete, and I have a small proportion of salary for an AHRQ grant. So today, what I'd like to do is organize the talk in sort of 3 parts to bring sort of everyone up to speed on definitions and epidemiology of delirium and POCD, but really with a focus on what's new in the past 2 years. a small section on summary of recommendations from various guidelines, and then the sort of final part will be to talk about optimization of brain health and really, again, focusing on what's come out in the past 2 years that can inform our practice. So I'm going to start with delirium. So as we all know, delirium is characterized by an acute and fluctuating course, characterized by inattention and disordered thinking. There are several different subtypes, including hyperactive, hypoactive, and mixed. We all sort of know the hyperactive subtype. The hypoactive is less easy to diagnose, but probably associated with similarly poor outcomes. Operationalizing the detection of delirium, the most popular method is the confusion assessment method, which really looks at 4 characteristics. To be delirium and CAM positive, you have to have characteristics 1 and 2, and either characteristic 3 or 4. And compared to a gold standard, it's probably greater than 90% sensitive and specific. Wes Ely operationalized the CAM ICU, which allows us to assess for delirium in nonverbal patients. And similarly, there's very similar criteria, but the answers to this require input, but not verbal. So are there fish in the sea? Squeeze my fingers if yes. Importantly, in similar populations, different methods of detecting delirium will give you different incidences. And this is illustrated in this slide, which gives ranges of incidence of delirium. And as you can see, there's probably differences across surgical procedures, with cardiac surgery and hip fracture surgery probably having the highest incidence of delirium. But even within similar surgeries and similar populations, different methods of assessment, so different tools, and also how you operationalize the tool that you're using will also give you different instances. And so it's important when you read the literature to sort of understand that caveat. Consequences of delirium, many patients make a full recovery, but as we've heard, there can be longer-term consequences. And I think this is really important and has sort of brought delirium to the forefront in the past probably 10 years. I want to focus on the cognitive consequences. So this is a seminal slide from the Boston group looking at mini-mental status exam after delirium in cardiac surgery patients. And what you can see is patients with delirium in the light gray line had worse mini-mental status exam scores in the days after surgery, recovery, but still decline at a month, and then again, somewhat recovery by a year with a trend towards worse cognition by mini-mental status in delirious patients after cardiac surgery. Now, we all know that mini-mental status exam has limitations, including floor and ceiling effects. So our group looked at So our group looked at this question a little bit differently using a cognitive battery. And so we administered a 1-hour-long cognitive battery before, 1 month after, and 1 year after cardiac surgery. And what you can see here is that at baseline, patients who got delirium in the dashed line had worse cognitive scores. At 1 month, their decline in cognition was worse than the non-delirious patients. And then out to a year, there was attenuation of that gap, and the difference was no longer significant. We were able to look at domains of cognition, and as you will shortly see, there were differences in domains and processing speed at 1 month and 1 year, and visual construction at 1 month, and a trend towards executive function were really the domains that stood out in terms of cognitive deficit at 1 month after delirium in cardiac surgery patients. I will say that there's been 2 other studies within the past year or 2 that have looked at this similar observation. And so the first study was in Europe. They again did a cognitive battery about an hour long in the perioperative cardiac surgery period. They had a 12% incidence of delirium. Our incidence is between 40 to 50% generally. But interestingly, they have the exact same findings. So at 1 month, the worst decline in cognition in the delirious patients with somewhat attenuation out at 1 year. Similar findings in a JAMA surgery paper looking at non-cardiac surgery. There's very little data past a year. This is the SAGES study from Sharon Inouye's group looking at 2-3 years out. And what you can see in this figure is that, again, they showed similar findings of a nonlinear trajectory after non-cardiac surgery by delirium status, with worse cognition in the month to 2 after surgery, resolution up to a year, but then at 2 to 3 years, they started to see a separation in cognitive scores. And so there's some problems with the study. There's a lot of missing data, but it's instructive to think about. And really, it also begs the question, what is the mechanism for these findings? So is delirium simply a stress test for the brain that identifies people who are going to have long-term cognitive decline? Are there potential injuries during the perioperative period that lead both to delirium and cognitive dysfunction? Or if you get delirium, do things happen to you? Do you get Haldol? Do you not sleep? Do you not exercise? Is delirium in the causal pathway? So this is an unanswered question, but clearly an important area of research. I don't know if they're... Okay. So I want to move to epidemiology of POCD and NCD. So as we all know, measuring POCD is difficult, and there are issues with what is the test battery to use, what time point do you look at, what are the cutoffs of decline to label someone POCD, do you use a comparison group of controls that haven't undergone surgery, and then what are your analytic methods? And so this figure that I'm showing you is incidence of POCD at different time points using different cutoffs. And as you can see, depending on where you set the time point or where you set the cutoff, you can get vast differences in incidence of POCD. To address some of this problem, as many of you know, there's new recommendations on nomenclature for cognitive dysfunction that really try and align our POCD research with community standards, including DSM diagnoses. And so I won't belabor this, but really they look at time periods from recovery, from surgery until 1 month until 1 year, and after 1 year, and really try and look in addition to cognitive change, but also functional limitations as well as subjective complaints. And so this was widely published in approximately 7 articles in various journals within the last year. What is the incidence of POCD? From my read of the literature, I'd say my best estimate is based on 2 studies, each over 1,000 patients. The IS-POCD study defined cognitive decline, or POCD, as a decline in 2 standard deviations in 2 tests or more, or a composite score, and they identified a 10% incidence of POCD at 3 months. This was similarly reported by Monk et al., who again looked at over 1,000 patients and found in the age group greater than 60, there was about a 12% incidence of POCD. So I think this is good observational data that is consistent across 2 studies, 2 continents, and over a decade apart. I think when you look at longer-term cognitive dysfunction, the data is less clear, and especially looking at these definitions of POCD, most studies have found limited evidence or a small prevalence of persistent POCD out to a year. I want to highlight this figure. It's a spaghetti plot of cognitive decline after hospitalization, and I want to do it for 2 reasons. One is probably we shouldn't just be looking at absolute cutoffs. We should be looking at changes in cognition in relation to how you were prior to surgery. And secondly is just to really highlight the vast inter-individual variability in cognitive slope after hospitalization. You can see some patients actually get better, perhaps due to testing effect, but there are a number of patients who substantially decline. And there are probably individual risk factors that we need to characterize more and think about in terms of our optimization. I think key risk factors include age, cognitive status, and stroke, but in addition, delirium, as we talked about, and critical illness, importantly. So there are 2 studies in this venue that I want to highlight that have come out in the past year. So one is an observational cohort study looking at patients enrolled in the Whitehall 2 study. So this is 7,000 patients with as many as 5 cognitive assessments over 2 decades. Of these patients, 4,000 had surgical hospitalizations and another 4,000 had medical admissions. You can see there's some people had multiple hospitalizations. And what they found was they looked at cognitive Z-scores over time, but also they framed it in terms of years of cognitive aging. So how much cognitive aging has you lost after hospitalization or surgical hospitalization? And what they found is that there is more of an effect after hospitalization that was medically related as opposed to surgically related. And there was an effect after surgical admissions, but it was less than after medical admissions. So as you can see here, in terms of years of cognitive aging, it was 1.4 years for the non-surgical admissions and 0.35 years for the surgical admissions. So I think this is nice to put into context, and especially to look at comparisons of surgical and non-surgical hospitalizations. In their data, they found that executive function and verbal fluency was more affected than memory. They also looked at what they called substantial cognitive decline, so more than 2 standard deviations, and again, similar findings. So in the non-hospitalized group, over time, 2.5% developed this. In the surgical group, approximately 5.5%, and in the non-surgical group, almost 13%. A group from Sweden, Eriksson et al., looked at a similar question, but with incident dementia as an outcome. And so in this study, they constructed 2 separate case control cohorts. One were cases that really had rigorous adjudication of dementia because they were enrolled in other studies. This was nested in the Swedish twin registry. The other case control study they identified was patients who had dementia diagnosis from really the electronic record or from registry. And so depending on the diagnosis of dementia, you can see the different numbers in their case control study. I'm going to show you data using the registry diagnosis, and what you can see is non-surgical admissions are on the left panel with hazard ratio of dementia in the y-axis, and you can see that there appears to be a dose-response relationship between incidence of dementia in this study and number of non-surgical hospitalizations. And on the right panel, you can see a similar pattern, but a little bit less for surgical admissions. So overall less, and the slope with each surgical admission less as well. Now, one particular question is, again, with surgical admissions, is there a bias? Is there a measurement bias because you're surveilling patients more in the perioperative period? So they looked at this in terms of hazard of dementia by time, and what you can see is that with time being on the x-axis up to 20 years after surgery, you still saw an increased hazard ratio, implying that it's not just a surveillance bias of people getting labeled dementia within the first year after surgery. So I'm going to switch gears and talk now about practice recommendations. There's been several guidelines that have come out and been alluded to. So the AGS and the ACS guidelines. There's been guidelines from the International Perioperative Neurotoxicity Working Group, and then a really nice review in BJA from the Brain Health Initiative. So these are I sort of summarized the literature in this regard. And so I say these are sort of 5 to 6 key points. So one, I think considering informing your patients about the risk of postoperative neurocognitive dysfunction. Many people don't. I think when you look at the incidence of delirium, it's really high, and this is something that we should consider informing our patients about. Assessing risk factors for delirium, including cognition, developing routine strategies for prevention, and then non-pharmacologic strategies to treat delirium, and really reserving antipsychotic agents for patients who pose harm to themselves or others. And then finally, there's this consideration of anesthetic strategies, and that's a lot of what we're interested in. So monitoring EEG, looking at cerebral perfusion, optimizing pain control. So I want to focus for the last sort of part of the talk on what's new in this area, what's new in strategies to optimize brain health in really the intraoperative period. So this meta-analysis looked at depth of anesthesia, and I'm going to sort of blow through a couple topics with 1 or 2 studies in each. So in terms of depth of anesthesia, a systematic review published in 2018 looked at 4 to 5 studies and said, yes, there is evidence in well-done studies, some over 1,000 patients, that optimizing depth of anesthesia in surgery can reduce the incidence of delirium. I would say within the past 2 years, there's been 2 studies that have come out that have kind of called question on this finding. So one is the STRIDE study from my mentor and colleague Fritz Sieber, looking at patients who have traumatic hip fracture undergoing spinal anesthesia randomized to light versus deep sedation. Light sedation would be responsiveness to voice with a BIS in the 70 to 80 range. Deep sedation would be responsiveness to sternal rub with a BIS in the 50 range. Preliminary data from several years ago suggested a 50% reduction in delirium in the light sedation group. In this follow-up study with probably better delirium assessments, they saw absolutely no difference. So an incidence of 34% and 39% in the light versus heavy sedation groups. You can see the Kaplan-Meier curve here. What was interesting is that when they did a pre-planned subgroup analysis by Charleston Comorbidity Index, they saw an interaction. And what they saw is that patients who had high Charleston comorbidity, the intervention did not matter. Patients who were healthier, there was a substantial reduction in delirium in the light sedation group. It was a subgroup analysis, so you need to take it with caution, but potentially an implication or an interpretation is that for patients who are very sick, there's a lot of things that will lead to delirium. This particular intervention might have been overshadowed by that and might be more effective in the healthy patients. It's unclear, but it needs to be studied further. Similarly, Mike Avedon's group published the ENGAGES study, where they built on preliminary data suggesting that burst suppression, so the time in burst suppression was associated with postoperative delirium. And they showed a nice dose-response relationship with that. So this is a pragmatic study funded by the NIA in over 1,200 patients, non-cardiac and cardiac surgery. The intervention, they trained individual anesthesiologists to look at the raw EEG and to avoid burst suppression and keep the BIS above 40. What they saw was no difference in the delirium incidence. They did see that they were able to reduce burst suppression from 13 minutes to 7 minutes in the intervention groups. They saw more undesirable movement in the intervention group. And then interestingly, they saw a signal for 30-day mortality that was less in the intervention group. This was one of many secondary analyses. And so again, interpret that with caution, needs further follow-up. I will say that, as you can see, the intervention was successful in reducing the duration of burst suppression. It was a small amount. But on the other hand, both 7 and 13 minutes were on the higher end of their burst suppression that was associated with delirium in their observational data. I want to move to cerebral perfusion. This is work from our group. So we're very interested in optimizing cerebral perfusion during cardiac surgery. We use Doppler and NIRS to really try and identify the lower limit of autoregulation for individual patients, okay? And this is sort of the canonical cerebral autoregulation curve that everyone knows and loves from medical school. When we use these methods in cardiac surgery patients, and identify the lower limit of autoregulation for individual patients, we see a wide array. So this histogram shows that the lower limit in 232 cardiac surgery patients ranged from 40 to 90. Implying that sort of one-size-fits-all empiric map targets may be inappropriate for many patients. So we've been conducting a trial where we've been identifying the lower limit of patients undergoing cardiac surgery prior to bypass, and then giving the perfusionist a target on bypass based on that lower limit. And then this was a nested study with delirium as the primary outcome. The overall trial had a composite outcome. But in this nested study of almost 200 patients, we found a significant reduction in the incidence of delirium in patients in the intervention group with personalized map targets during cardiopulmonary bypass. So single-center study, it was a nested secondary outcome, but I think intriguing and worth following up on, potentially implying a cerebrovascular contribution to delirium, and clearly needs to be studied further in multiple centers. Bala's in the audience. This is his study looking at sedation and pain in cardiac surgery patients. This was the DEXA-SET study. It was a 2x2 factorial design looking at IV Tylenol, 1 gram Q6 times 8 doses versus placebo. The second factorial design was dexmedetomidine sedation versus propofol. What they found was that there was a reduction in delirium, so the top graph right here, in the IV Tylenol group versus placebo, so 28% versus 10%. Less opioids and reduced length of stay of ICU in the intervention group. Interestingly, there was no difference in delirium by the sedation strategies of propofol versus dexmedetomidine. Again, this was a single-center study, very intriguing results that will be followed up in a multi-center fashion. I think the issue of pain control is interesting to us, and there's actually not a lot of great data on the use of epidural in terms of delirium. And I think when you look at the risk of delirium, pain is a risk and opioids are a risk. So how do you get around that? So this was a secondary analysis of the podcast study. And as you recall, the podcast study was a study looking at ketamine and postoperative delirium. And in this nested study, they looked at 263 abdominal, urologic, or gynecologic surgery patients. They found that epidurals were used intraoperatively in 74% of the patients who had epidurals and 97% before post-op day 1. When they looked at patients with epidural versus without epidural, there was no overall difference in the incidence of delirium. But I want to highlight the first column here was PACU delirium. And so what you can see is that that result was really driven by PACU delirium. When they did a secondary analysis looking at the odds of individual incidences of delirium, the results were significant, favoring the epidural group. So I think this really bears further investigation, and I think would really comport with what we would think is that regional techniques, epidural use, and opioid-sparing approaches can be effective in reducing the incidence of delirium. To conclude on sort of the delirium part, a lot of people have been talking about dexmedetomidine. There's been several studies that have come out. This is a meta-analysis which looked at 18 RCTs looking at post-op delirium after dexmedetomidine. They did suggest an overall benefit. I want to walk you quickly through the subgroup analyses. So the benefit was similar, cardiac or non-cardiac surgery. Previous slide. This slide, you can see that there is benefit for patients who got dexmedetomidine intraoperative only, or postoperative only, but interestingly not for patients who got it through the continuum. And so that is unclear why. There's a small number of studies in that group, but that bears further investigation, and was similar in the young versus old patients. A question that I think is important to focus on and think about is all delirium the same? So when I was sort of brought up through the research world, they said, it doesn't matter how you got delirium. As long as you meet the CAM criteria, that's important. And that may be true. Nevertheless, I want to consider this study briefly. This is a study from my colleague, Rebecca Gottsman, looking at long-term mortality after cardiac surgery among patients who had delirium. You can see over 10 years, the mortality is substantially higher in delirious patients. But what was interesting is that it was different by how vulnerable they were. So if you were vulnerable, if you were older and had a history of stroke, the effect of delirium on mortality was substantially attenuated. But if you were less vulnerable, so younger, no history of stroke, this difference in mortality was exaggerated, potentially implying that patients who are less vulnerable and get delirium experience a greater insult. And so this is a study from 2010. Last year, a similar study was reported in the medical literature using frailty as an index of vulnerability. And in this study of 700 medical inpatients, they found strong associations with delirium and mortality, as well as frailty and mortality. And importantly, they saw an interaction. So if you got delirium and you were in a frailty tertile that was high, that effect and association with mortality was substantially reduced. If you were low frailty, so resilient, and you got delirium, the risk of mortality was increased. So I think understanding how you got to delirium, I think is an important future direction. I'm going to finish the talk just on interventions and practice for POCD or NCD. I want to highlight 3 studies. So this is the Neurovision study. It's an observational cohort of more than 1,000 patients, 12 centers, 9 countries, looking at covert stroke after non-cardiac surgery. They also looked at delirium and 1-year cognitive decline. The results are intriguing. So in this non-cardiac surgery population, 7% had a perioperative covert stroke. Patients who had delirium, or patients who had a covert stroke, had twice the risk of delirium and a substantial increase in 1-year cognitive decline, at least by a MoCA score. So I think this is going to clearly bear further following up, because this is a surprisingly high incidence after non-cardiac surgery. We talked previously about critical illness. So this is a cohort study from the Mayo Clinic Study on Aging. They looked at 3,000 patients with long-term follow-up. 300 had ICU admission. At baseline, their cognitive status was no different, but as you can see, over 5-year follow-up, patients who had ICU admission in the dark gray boxes had worse cognitive change out to 5 years. This was all comers in the ICU. There was no difference in medical versus surgical ICU admissions in their study, and the greatest decline was in domains that we think about in the perioperative literature, so memory, attention, executive function, and visuospatial. And then I want to conclude by thinking about and looking at the study on regional versus general anesthesia. So does that matter? It's a difficult question to answer with long-term follow-up. So this study, again, was nested in the Mayo Clinic Study on Aging. They looked at patients who who had a cognitive slope prior to surgery. They looked to see how did the slope change after surgery and compare the anesthetic technique of general anesthesia or regional anesthesia. What you can see is that compared to the cognitive slope prior to surgery, if you had either a general or a regional, your cognitive slope worsened. There was no difference between having a general or a regional anesthetic. In subdomains, there was no difference in many of the domains, including language, attention, executive function, but there was a worse decline in memory in the general group compared to the regional group. So hypothesis generating, but I think important to think about and talk about. So that's sort of a brief whirlwind of what has come out in the past year to two in terms of optimizing brain health. And so I think, future directions are understanding really the pathophysiology and modifiable risk factors for both delirium and cognitive decline, really understanding how someone's preoperative trajectory relates to their intraoperative and postoperative course and then their long-term trajectory, and really using that information to develop targeted prevention and treatment strategies. Thank you.
Thank you very much, Dr. Brown. I'm going to have you sit down there, and I'm going to ask Dr. Rosenthal to come back up. And while we're going to figure out what's going on with the sticky clicker for advancing the slides, I'd like to invite people to come up to the front and ask any questions of our featured speakers. I know we're all anesthesiologists. We can adapt to this big room. And I'm sorry to make you walk, but the microphones are up here and up there. So.
Hi, thank you very much. John Capacchione from the University of Minnesota. We all have that geriatric patient who's on 15 medications. And you look at them and you go, I have no idea what the bioavailability is of any one of these drugs that they're taking. On average, we give another 11 medications in the perioperative period. As anesthesiologists, we focus on the lungs, the heart, and the brain. Are we missing something and not looking at the other end of the patient and the microbiome? We give everybody antibiotics, we disrupt their microbiome, but we never look at what their baseline microbiome is and what their microbiome is postoperatively. And a lot of drug metabolism is involved in our microbiome. There's a reason old people are focused on their bowel movements, and I wonder if we are missing something by not looking at the influence of the microbiome on all of this.
Yeah, no, I think that's a really important question and probably an active area of research now. We've clearly seen ways that the microbiome can impact health and ways to even modify that, right, with fecal transplants. We heard some interesting data last night at the Society for the Advancement of Geriatric Anesthesia, the SAGA meeting, with an abstract looking actually at RNA differences in microbiome and leading to differences in different classes of bacteria in the microbiome in animal models before and after anesthesia and surgery. And the data showed differences even at a day after, and some of those differences then were associated with changes in a measure of mouse cognition and potentially modifiable. So I think it's a great question. It's sort of a ripe time as other areas are thinking about the microbiome, but there's not a lot of data even looking at how the microbiome changes in older adults after cardiac and non-cardiac surgery. So we're starting to do that at our institution and just doing an observational cohort study, even characterizing basic things about change in microbiome after surgery.
I can just make one surgical kind of remark about that, just to agree with that, because in bowel surgery, there's great literature that says you shouldn't be prepping the bowel before you operate on the patients, that they do much better, and in Europe, patients don't get that much bowel prep, but here we still are prepping the bowel, and I'm sure that part of that benefit is because we leave the microbiome unaffected during the case.
Hi, my name is Ronnie Liu. I'm a community anesthesiologist. I get a chance to come to one of these meetings about every 3 to 5 years, and I applaud all the work that you guys are doing. But every time I come, I get a little bit more confused. Last time I came, one of the focuses was on pediatric anesthesia and how the anesthesia doesn't affect the brain. We tell, one family in one pre-op bay, don't worry, I'll take care of your child. They're going to come out just fine. The anesthetic, all the data shows it doesn't affect your brain. Then we go and take care of an 85-year-old and say, sorry, the anesthetic is going to scramble your brain for a little bit. And so there's a little bit of a disconnect, and I think there's a lot of similarities between pediatric and geriatric anesthesia. And I think one of the focuses that has been missed is just the surgery itself. And you're finding differences with regional anesthesia and general anesthesia, and then you're finding lots of studies with no differences between regional anesthesia and general anesthesia. But the common factor is the surgery itself, and that's being left out. Can you guys comment on that, the stress of surgery, the cortisol levels? We know in children, for instance, there's a big focus on adverse childhood events, ACEs. None of those kids are having surgeries, yet we know their brain is different than somebody who doesn't have those stressors. And perhaps that's the common link that we're not looking at.
Yeah, so I think there are a lot of points to respond there. And so one is the notion of conflicting messages or things that evolve over time. And I think that's true. I mean, I think there are studies that come out that change our conclusions or modify some of them. And so I think, in some of these talks, it's important to sort of summarize the current state of the literature, but also identify the individual studies that have really contributed to that in individual patient populations. And even two of the studies that I talked about with depth of anesthesia, they're very different patient populations. A traumatic hip fracture patient is very different from a patient undergoing general surgery in an elective fashion. And so the results, may be only unique to those populations. I will say that I 100% agree in the notion that it's very hard in sort of the clinical research world to separate the effects of surgery and all that comes with that from the effects of anesthesia itself, right? You can do that in the mice, but it's really hard, and one or two people have looked at that, but it's really hard to do it in sort of clinical practice. I do think that a lot of the insult comes from the perioperative period and isn't not just limited to the anesthetic agents that we administer. That being said, my read of the literature is that the patient vulnerability is probably more important than what happens in the OR. So the patient who comes who's 85 and has cognitive impairment, their risk of delirium is substantially higher. And we're going to focus on modifiable risk factors that we can change to attenuate that. But their underlying risk, in my mind, drives the bulk of the burden.
Yeah, and I agree with that too, because if you think about frailty and how complex the inflammatory process is involved with frailty, and then have that interact with the stress of surgery and everything else, that it's hard to just pick out which of the pieces are the ones in the interaction.
So we'd like to thank you for all of those spectacular questions, but for the sake of time and so that we can make sure that all of our posters are adequately presented, I'd like to thank Dr. Rosenthal and Brown for such wonderful and spectacular lectures. Can you join me in thanking them? I am next going to give a tutorial on how to use the clicker. This is a green button right here. They're finicky. I've used these before. Press and hold gently and let go. Voila! Now I don't know how to get back, but let's see if I can do that as well. Probably not, so the first speaker will be stuck with that. There are a couple of things I'm going to tell you. There's 7 minutes per presentation and 2 minutes of question and answer afterwards. If you try to go over, one of us is going to come up here and invite you to go sit back down. So please try to keep your presentations on time. We won't cut you off, I promise you. I'd like to start by introducing our first presenter today. That's going to be Dr. Rangzami. And if I said your name inappropriately, you can beat me up later. His talk is on preoperative blood pressure complexity and frailty in cardiac surgical patients. Would you like the clicker?
How should I? This way?
This one right here.
Oh, okay. Morning, everyone. My name is Valluvan. I'm a pediatric anesthesia fellow at Riley Children's. Yes.
Do you want to say next slide and I'll try to do it?
Yeah.
Okay.
We all know elderly patients have an increased risk of perioperative adverse complications, but not all elderly patients have the same risk. This led to the concept of frailty, which is basically a concept of biological rather than chronological age. Frailty is a state of decreased physiological reserve, and it has been associated with increased risk of adverse surgical outcomes. But there are two important things here. There is no universally accepted tool for frailty, and especially in the perioperative setting. Also, the mechanism of frailty-related complications is not fully understood. Autonomic dysfunction is common in frailty, and it has been found as a better predictor for frailty and mortality, especially in elderly patients. Recently, blood pressure variability due to autonomic dysfunction has been proposed as a mediator for frailty-related complications. The same blood pressure variability can be used to compute complexity. Complexity here is the physiological adaptability of a system, and it decreases with age and pathology. So based on these facts, we hypothesized complexity could be a marker for frailty and looked into the association in cardiac surgical patients. Previous slide.
Pardon me?
No, this, I want the previous slide. No. Methods?
You want methods?
Yeah.
Just twice.
No, the previous slide, previous one.
Did you say you wanted methods?
Yeah.
It's,
Yeah, this one,
okay,
yeah.
yeah.
So 364 adult patients undergoing elective cardiac surgery were included in this study, and we captured their preoperative invasive beat-by-beat blood pressure. We computed complexity measures from these blood pressure waveforms using multiscale entropy analysis, and frailty was measured using a recently published chart-derived frailty score using preoperative patient variables like age, BMI, hematocrit, albumin, and creatinine. Our primary aim was to look into the association between frailty and complexity. As an exploratory analysis, we looked into the predictive ability of frailty, complexity, STS risk index, and a combination of complexity index and STS risk index towards 48 hours ICU length of stay as an outcome. Yeah, just few words about the methods. Complexity was measured using multiscale entropy method. We had 3 indices: complexity index, slope of complexity index, and a product of these 2. Frailty was measured using these 5 variables: age more than 70, BMI less than 18.5, hematocrit less than 35%, albumin less than 3.4, creatinine more than 2. Around 50% of our patients had frailty. The complexity indices were significantly decreased in frail patients. Also, these indices demonstrated fair predictability of frailty. Coming to the exploratory analysis, our complexity measures, the predictability was similar to frailty and STS risk index. However, on adding complexity measures with STS risk index, we couldn't find any improvement. So, this is the baseline patient features. Our median age of patients were around 67 years. The next one. No. Yeah. Here we can see complexity measures significantly decreased in frail patients, and also they demonstrated fair predictability. This is a table showing the predictability. Our complexity measures had similar predictability of frailty and STS risk index, but on adding complexity measures with STS, we couldn't find any improvement. We found a significant relationship between frailty and complexity, most probably due to autonomic dysfunction. We conclude that complexity measures measured from preoperative blood pressure could be a marker for frailty. And these measures, either alone or in addition with standard frailty indices, could accurately quantify frailty. The take-home message is, if we could find a tool that is closely related or influence or interacts with the underlying pathophysiological mechanism of frailty, it could be a better marker. I would like to thank my team from Beth Israel and ASA for giving me this opportunity.
So that was not you. Our clicker is not working. Imagine that. We've tried it multiple times. Congratulations, beautiful presentation. Thank you so much.
Thank you.
Do we have any questions about our first presenter? And thank you for hanging in there while we try to figure out the clicker. I know how hard that is when something doesn't work when you are trying to present your stuff. Yes.
So if frailty affects complexity, we worry a lot about hypotension.
Yeah.
And so will someone who is frail or someone who has less complexity in their blood pressure response exhibit greater degrees of hypotension in the OR?
Exactly. Yeah.
Did you see that? Did you see
no,
that?
no, we didn't see that. We just looked into the association between frailty and complexity.
That means that you were right on time and did a spectacular job. Thank you.
Thanks so much.
Okay. We are going to ask all of the presenters to now say next slide when you'd like to have your next slide come up. I know that that's a little interruptive, but that's probably the only way your slide's going to go forward.
Is that because they're going to manage it from behind us?
Yes.
Okay. All right. Well, our next speaker is going to be, is it Dr. Michael Pronowski from the University of Wisconsin. He and his group have a great abstract on age modifies the effect of anesthetics and hyperoxia on traumatic brain injury outcomes in fruit flies. So.
Exactly.
Yeah.
So whether you see the slide only, okay, so let's, it's complex if you don't advance your slides yourself.
Your
But,
slide should be right there. Is that your
right,
first slide?
yes, well, apart from the title slide, yes, it's the first
Can we
slide.
go
Okay.
back one slide?
That's fine,
please?
no, let's leave it, let's keep on going. So, the important message is that we're going now back 400 million years in evolution. And I would like to convince you that it's worth reading articles about fruit flies, even if you think that they're completely irrelevant to human care. I will try to show you a couple of data that may give you the impression of what we can get from the fruit flies. So, we know now traumatic brain injury is a big healthcare problem. Traumatic brain injury increases in the old, and in the old, the outcomes are worse, okay? So, traumatic brain injury is separated into primary injury and secondary injury. The only thing you can do about primary injury is try to prevent it. Once the injury has happened, we're getting into the secondary injury phase. Now, the good thing about secondary injury is that it involves fundamental, ancient cellular response systems to insult or injury. Next slide, or forward, okay. So secondary injury is mediated by evolutionary conserved pathways. Next slide, please. Why is this good? Because we can use simpler organisms to understand the cascade that happens after TBI. So, I will quickly present you data that has been published about traumatic brain injury in Drosophila melanogaster. Let's start advancing. So, we have temporary incapacitation, next, ataxia, next, death within hours of injury, activation of the innate immune system, next, neurodegeneration, next, and reduced lifespan. These are all findings that we can reproduce in the fruit fly, which also exist in the human. Next slide. So, the TBI, and what we know from TBI in the Drosophila melanogaster in our model is that it's the brain injury component that determines mortality. Next slide. So, these are similarities to human TBI. Advance. Please advance. So, we have a concussion severity score for the fruit flies, which correlates with 24-hour mortality, indicated by a cross. the mortality increases with injury severity, next, increases with age, and a progressive lifespan reduction with increasing injury severity. So we have very similar, we reproduce a lot of the findings that we have in TBI in humans in fruit flies. Next slide, please. And what is the advantage of the TBI in fruit flies is that we have a no animal welfare concerns, we do whatever we want with the flies, and we have an amazing genetic toolbox in order to understand the genetics of traumatic brain injury and of the effects of anesthetics on outcome. Next slide. So this is just to get you used to what you're going to be seeing. In young adult, we have published this a year ago. So anesthesia prior to TBI with inhaled agents reduces mortality 24 hours after TBI. By contrast, anesthesia after TBI with isoflurane within 24 hours increases the mortality. We don't have a pointer, right? Or this one can use it? No. Okay, so you can see these bars. This is what you will be seeing on the next graphs. So the white bar is a control bar, and then the colored bar will have different combinations of drugs. And the mortality is the y-axis is the mortality index. The higher, the worse. The higher the mortality. Next slide, please. Next. So what we're going to do in this project, what we did in this project, is test the hypothesis that aging-related processes affect interaction between TBI and anesthesia. Next slide. Okay, and the experiment consists of, next, continue, isoflurane or sevoflurane, continue, with or without hyperoxia. That's an important point. Next slide. So we have the brain which is naive. That means that we administer the anesthetic or the drug combination before trauma. Next slide. Or we have the injured brain. And we will have a young and an old animal group. Next slide. And the readout is the 24-hour mortality after TBI. Next. And so this is the experimental setup. I'm going to go quickly through it just to show you that we have the pre-exposure modality. We then have the post-exposure modality. And the bottom shows you how difficult it is to do the appropriate controls. So for every experimental group that you can see in the right bottom corner, we have at least 3 control groups. And we always run young and old flies in parallel to control for changes in the health, in the colony health and stuff like this. Okay, next slide. So we used a very complicated log binomial regression analysis because of the complexity of the interacting factors and a number of control experiments. So mortality increases with age for a given injury severity. Next slide. Let's go ahead. Next, go ahead. And so this is the first results of pre-exposure. And I'm sorry that I don't have a pointer because I would like to look at the green. On the left, B and E are young animals. On the right, C and F are old animals. You can see that if we expose young animals to oxygen prior to surgery and prior to the trauma, and then there is no effect on outcome. The green bars in the left in the left corner. However, if you expose old animals to oxygen, there is a trend. It doesn't reach significance. There's a trend towards an increased mortality after trauma. The same thing, if you expose young animals to isoflurane prior to trauma, you reduce the mortality substantially. Same thing is true for sevoflurane, the yellow bar below. However, if you do the same maneuvers in the old animals, you actually do not. You lose this protective effect of pre-exposure. Let's have the forward. So the summary is that aging-related changes, forward, loss of protective pre-exposure effect by volatile anesthetics, next, and a trend toward harmful effect of hyperoxia. And now we'll switch to the postoperative. Let's go to the post-trauma exposure. And here you can see there are, again, differences between young and animals. They get exposed to the same drugs, right? But what we have in the old, let's start advancing. So what we have in the young, there is no effect of hyperoxia after trauma on mortality. It doesn't matter whether you anesthetize them with isoflurane, sevoflurane. In the old, hyperoxia after trauma increases mortality. Now, in the young, exposure to isoflurane increases mortality, but not to sevoflurane. And this reverses in the old. Sevoflurane after trauma increases mortality in the old. Isoflurane has the same trend, but doesn't reach statistical significance. Most interesting is the combination on your right, far right side in C. is the combination of isoflurane and oxygen. Isoflurane in hyperoxia, 75%, dramatically increases mortality if you administer it after TBI. Sevoflurane is a more complicated interaction. So let's advance once more. Can we advance? Can we advance? So sevoflurane increases mortality more than isoflurane if administered afterwards. And so the important thing is that there is a differential interactions between voluntary anesthetics and hyperoxia in the old injured brain. The biological context matters. Next slide. Okay, so let's summarize. In young adults, pre-exposure to both VGAs reduces 24-hour mortality. It's like a preconditioning-like effect. We don't know what the mechanism is. But the post-exposure in young animals, only to isoflurane but not to sevo, increases mortality. In the old adults, it becomes much more complicated. Pre-exposure, we lose the preconditioning effect in the old brain, which is interesting. So pre-exposure does not reduce mortality. Post-exposure to sevo but not isoflurane increases mortality, and hyperoxia becomes damaging. That's a kind of like a very important take-home message. Can we have the next slide? The outcome of it, okay, so the important thing is, again, that we have outcome between volatile general anesthetics and molecular actors in the traumatized brain and in the healthy brain. But the outcome from these interactions is different, the outcome on mortality. So I don't think that I have time to talk about the plans for the future. That's the talk. Thank you.
Any questions up at the microphone? Otherwise, actually, my question actually is plans for the future. I would like to hear about what the future of this is, because it's very interesting work.
Well, we want to, basically, we think that there is a genetic component that drives these interactions. And so we think that we can identify markers that predict whether an anesthetic, and we were just talking about these two inhaled agents, will have a detrimental or possibly a beneficial effect on outcome in this model. However, we have other, this model has to be widened, we have to use develop different outcome measures and stuff like this. But in general, the most important take-home message is really that the injured brain is not the same as the healthy brain, and this seems trivial, but we don't think about that. We think that we administer an anesthetic to a healthy brain, the outcome is going to be the same as with the injured brain, and this is not true. The biology of the injury in the brain changes its interaction with anesthetics and may show you problematic things or actually beneficial things. We don't know, because there is both this beneficial and the detrimental outcome depending on age and other factors. Okay, thank you.
Thank you.
That was excellent. We have our third speaker now, Ann Donovan from UCSF, and she's going to talk to us about the impact of delirium prevention and treatment pathways on perioperative admissions, administration of Beers criteria medications. I'm going to try to click this. Can you please take us to her first slide?
Okay. Thank you. Good morning. We'll go to the next slide. No financial relationships except to say that I have a small pilot grant from the Nidus Foundation. By way of background, over the past 3 years at our institution, we have developed and implemented a perioperative delirium prevention and treatment pathway. I recognize that this slide is complicated, but I wanted to mention that it's a multifaceted pathway that's been developed in conjunction with hospital-wide delirium reduction efforts with preoperative, intraoperative, and postoperative components that are primarily based on some of the best practice recommendations that we heard about earlier today. Today's abstract really just focuses primarily on the medication management parts of this pathway, which were aimed at reducing administration of perioperative Beers criteria medications. We heard earlier today that the Beers criteria is a set of best practice recommendations published by the American Geriatric Society with the goal of essentially improving medication administration practices for older adults. Next, please. To distill this pathway down into sort of just a few bullet points, we start by screening all of our adult surgical patients in the preoperative area with the delirium risk screening tool called the AWOL-S. For any patients who screen at high risk, there are pre, intra, and postoperative management recommendations for our anesthesia team. We also introduced a novel PACU order set for these patients, and we emphasize interprofessional communication between the anesthesia, surgery, and nursing teams so that this pathway can continue uninterrupted in the postoperative period. For encouragement of compliance sustainability, we conducted an educational campaign for anesthesia, surgery, and nursing departments and launched an intensive QI intervention and made a number of enhancements to our electronic health record. Next, please. This slide shows just a few examples of some of the elements of our pathway. These figures are the medication management recommendations that are made by the pathway. The next figure is a screenshot of part of our novel PACU order set where anesthesia providers are required to select whether patients have standard delirium risk or high delirium risk. For high delirium risk patients, 3 of the Beers criteria or potentially inappropriate medications are eliminated as opt-in selections for the PACU timeframe. A few of our EHR enhancements are shown here. This is a flag that comes up in the medical record for patients who are screening at high risk for delirium. The next figure shows some intraoperative reminders that come up also for patients who are screening at high risk of delirium. Our timeline for launch of this pathway is pictured on this slide. The baseline time frame is considered August through November of 2017. This is when we were doing delirium risk screening throughout the hospital on all of the floors, as well as in the preoperative area, but we were not providing any focused delirium reduction efforts during that time. The implementation phase followed over a several-month time period. We rolled out the pathway, launched the new PACU order set, and introduced a number of the electronic health record enhancements that I already went through. And our intervention time period started July 1st of 2018, where we started to conduct active department-wide education on use of potentially inappropriate medications. The PACU order set was in use, and we were providing continuous feedback about compliance with appropriate order set use, and the EHR enhancements were all in place. Next, please. For the analysis part of this abstract, we compared rates of potentially inappropriate medication administration during the baseline and intervention time periods. Next, please. We looked at the time period between anesthesia start and PACU end, and looked at only patients who are 65 and older and admitted to the PACU. There were 2,629 patients in the baseline group and 5,736 patients in the intervention group. Next slide, please. And then you can keep clicking through. There's some, so going back to, if you could go back, please, thank you. Sorry. So just focusing on sort of we'll start with the top rows. These are our results. The Beers criteria medications are highlighted in orange text. Those are the group sort of, again, at the top and the bottom of the screen that included all of the Beers criteria medications that we looked at. Over the timing of our intervention, we were able to decrease perioperative administration of these medications from 31% to 24%. In the next row in green text are what we considered our preferred antiemetics, and administration of that group of medications increased from 34% to 38%, whereas administration of sort of non-preferred antiemetics decreased from 3.8% to 2.3%. If you look at the next 3 rows that are highlighted in blue text and sort of drill down into which individual medications made these differences, primarily decreases in midazolam and prochlorperazine administration were responsible for the effect that we saw. We also saw an increase in administration of haloperidol as an alternative antiemetic, which was part of our recommendations. And then finally, sort of down at the bottom of the slide, if you could advance just one more, we did not see a difference for the remainder of the medications that we looked at. So in conclusion, we launched a perioperative sort of practice change intervention, including education about potentially inappropriate medication use in older adults, launch of a PACU order set, and introduction of electronic health record enhancements that resulted in practice change in perioperative medication administration, primarily from decreasing administration of midazolam and prochlorperazine. We are still in the process of looking at impact on outcomes to patient care.
All right, thank
Thank
you.
you.
Questions for Dr. Donovan about this intervention at UC San Francisco?
I have one. Did you see any difference in outcomes with this intervention?
We are still we're in the process of looking at that, but so from a hospital-wide standpoint, we have seen quite a few outcomes improvements with the delirium reduction campaign, including decreased length of stay, decreased delirium incidence prevalence, delirium days, and things like that. In the analyses of the surgical patients that we looked at, which is very much kind of a before and after methodology, we have not seen those same outcomes changes.
What type of power analysis was done, and what type of sample size will you need in order to show a difference in outcome based on the change that you see in prescribing?
We actually did not do an a priori power analysis, but.
Okay, very good. Thank you so
Thank you.
much. Our next abstract is preoperative ultrasound-based frailty assessment as a predictor of surgical outcomes. So I'd like to invite Dr. Cecilia Canales to come up and present that abstract.
Hi, thank you everyone. My name is Sassy Canales. I'm a CA1 resident at UCLA. Had the opportunity to start working on this as an intern. I have no disclosures and none of my co-authors have any study-related disclosures. So talking about ultrasound assessment and frailty, but I don't think that this is the updated lecture series slides.
I think we'll have to go with it. This is what we have.
Okay. So frailty is a decline in physical and cognitive reserve leading to increased vulnerability and stressors such as surgery or other disease states. Frailty is associated with increased symptom burden and adverse clinical outcomes. So what is frailty? Frailty is a phenotype that has been well described to include decreased status in mobility, muscle mass, nutrition status, strength and endurance. If you look at frailty as a syndrome with fit patients having a higher baseline health and more frail patients having starting with a decreased baseline health, the stress of surgery can reduce their health and outcomes are reduced the more frail a patient is. So how do we measure frailty? There's a lack of consensus about best methodology for identifying or predicting frailty. There are some physiological phenotypic methodologies looking at weight loss, exhaustion, weakness, physical activity. And there's also another school of thought that looks at more deficit accumulation. So looking at biomarkers, neurocognitive exams, radiological exams, and that's what we focused on here, looking at sarcopenia really as a measure of the biomarker, of the biological sense. So many frailty assessments have been created. There's over 300 different types of frailty assessments that have been used. There's really no gold standard. From a physiological biomarker standpoint, the Fried phenotype is one that's used most common. And another methodology radiologically has been CT imaging, looking at psoas muscle quality and quantity, and that's been validated in cardiothoracic populations. We looked at ultrasound as a point-of-care methodology, something that we can use easily, inexpensively, does not provide any additional risk to the patients that can objectively identify frailty. Our design, it was a prospective cohort study. Patients who were presented to the preoperative clinic were recruited to participate in the study. Inclusion was adults over the age of 18, scheduled for surgery, and had already a pre-procedural CT. Exclusion was no ability to consent to participate in the study, any lower limb amputation or muscular dystrophies. So what we did was, once the patients were enrolled, we classified the patients as frail or non-frail using the Fried phenotype. So the patients went through a battery of assessments, as they do with the Fried phenotype, looking at the get up and go speed, the walking speed, grip strength, a series of questionnaires looking at exhaustion and activity, and unintended weight loss. We then took the CT scans and looked at the psoas muscular area and measured it at the inferior border of the L3 on the vertebrae, which has been shown to correlate with CT psoas. And quadriceps measurements, we measured from the ACES to the patella, and at 60% to standardize, we did scans to look at the muscle depth from the skin to the femur. And outcomes that we looked at were hospital length of stay, ICU length of stay, delirium, rehospitalization, discharge disposition, wound dehiscence, and in-hospital infection. Unfortunately, this isn't the most updated slide, so don't have the updated information. We actually recruited 21 subjects. We had 12 subjects in the frail, 9 in the non-frail. There was a tendency, the groups, the demographics of the two groups were similar. There was a tendency towards older in the frail, but it was not statistically significant. There was no differences in sex, race, BMI, or ASA status. For outcomes, there were statistically significant differences in the quad depth, and in addition to this, to the quad depth, we actually also looked at the rectus femoris surface area, and there was statistical significant difference for the frail patients with less muscle mass in that area. In terms of outcomes, the only things that were statistically significant were discharge disposition. 100% of the non-frail patients went home, where patients in the frail group were more likely to go to a skilled nursing facility, so their discharge disposition was different. In terms of other outcomes, there were much greater events for the frail group, longer ICU and hospital length of stay. There were more falls, more instances of delirium, and but they did not reach statistical significance. This is just an example of two of our patients, one that is frail and one that is not frail. And you could see that the psoas area for the frail patient is much smaller with lower depth at the quad for the frail patient. And there was correlation between frailty and psoas muscle area, while frailty and quad, while adverse post-surgical outcomes, including rehospitalization, as I said, was greater in the frail group. So in summary, using point-of-care ultrasound to measure quantity and quality of the quadricep muscle correlated well with frailty and correlated with higher incidence of frail patients had worse incidence in outcomes. So our limitations were that this was a limited sample size, single center. Any questions?
I think you should be very proud of yourself. I know how hard it is to present when you've got your slides from yesterday still there.
Yeah,
but you did
I
a
had
great
some
job.
area under the curve that I was going to show in terms of other results and other things, but
So
I
I have
apologize.
a question. Did you look at the correlation between the measurements for the muscle and the patient's overall body size, BMI
So-
or height or?
yeah, we did. So there actually wasn't a difference in terms of BMI. We haven't done in terms of BSA. We didn't look at that analysis. But I think one of the concepts of frailty is that people tend to think that the skinnier, if you're frail, you're very young, or you're very cachectic, but you can be very obese and frail. So not seeing a difference is actually not surprising.
Charlie?
Thanks. So I think resilience is the opposite of frailty. So
Yes.
I think resilience is being measured here and
Yes.
adapting to things. So that's great. My question is more focused on this. So the correlations between the radiographic measures and frailty, did that differ depending on how you measured frailty? So the Fried phenotype versus sort of the Rockwood index?
So we didn't do a separate analysis, so we used the Fried phenotype specifically as our measure.
All right, very well done.
Thank you.
Thank you. So our next abstract is from investigators at Beth Israel Deaconess Medical Center in Boston, Dr. Murugapan, predicting adverse discharge to skilled nursing facility after inpatient surgery.
Thank you. All right, so postoperative outcomes such as 30-day mortality and operative complications reflect surgical safety. And while safety is important, there's growing interest in more patient-centered outcomes. In my work as an intensivist, the question I'm asked most often by patients is, when will I go home after surgery? As anesthesiologists, we see patients who come into the operating room multiple times during an admission. Oftentimes, these patients will harbor misconceptions. This is going to be the last procedure I need before I get to go home. These conversations become more difficult when we have to tell patients that they're not going to go home, and in fact, they're going to be discharged to a skilled nursing facility. More than just missing out on the comforts of home, their family, their neighbors, their friends, their pets, certainly better food, a more comfortable bed. Adverse discharge to skilled nursing facilities is actually associated with increased long-term mortality and functional dependence. There's considerable overlap between frailty, which has been discussed here, and adverse discharge. But we decided to kind of fast forward to the bad outcome to begin with. Frailty alone does not predict adverse discharge. And by looking at traditional markers of frailty, such as comorbidities, we wanted to actually take things a step further. And so we looked into things such as length of stay prior to surgery, as well as socioeconomic factors. With this in mind, our goal was to create a broadly applicable risk score using data available to anesthesiologists and other perioperative providers in the preoperative period to predict adverse discharge. Our population of interest was home-dwelling adults undergoing same-day admit surgery. We excluded patients under the age of 18 and those with missing data. Our primary outcome was adverse discharge disposition, which is defined as in-hospital mortality or discharge to a skilled nursing facility. We created our model using multivariable logistic regression, and again, we used features such as comorbidities, demographic factors, and other markers of socioeconomic status, as well as surgery features, including surgery type. The final variable selection was done through stepwise backward regression. We used a p-value of less than or equal to 0.01 as the criterion for inclusion. We also did interaction analysis to test the value of each retained predictor in the model based on age less than or greater than 65. We evaluated our model discrimination using area under the receiver operating characteristic curve, and model accuracy was assessed with a Breyer score. Following this, we externally validated our score in a separate data set from a different hospital. Here we actually have the study flow diagram. So you can see our derivation cohort that was from Beth Israel Deaconess Medical Center. We included patients undergoing inpatient procedures under general anesthesia or monitored anesthesia care. Our final cohort consisted of 99,371 patients, and 15.7% of those were actually discharged adversely. Our validation cohort was from, if we can go back, was from Massachusetts General Hospital, and the final cohort there consisted of 91,493 patients, 8.2% of whom were discharged adversely. This is actually the score itself. So you can see the final model incorporated 18 predictors of adverse discharge, and the weighting of values ranged between 1 and 20. Procedure type was a very important predictor, with musculoskeletal and trauma surgeries conferring the greatest risk. Interaction analysis, again, resulted in different weighting, which you can see towards the bottom of the slide. Age itself was a major predictor, conferring a great deal of risk, but there were important differences as well. You can see certain specific types of surgeries, including intraperitoneal and trauma procedures, conferred greater risk. Additionally, by dichotomizing insurance status by age, we're able to reflect the complex interplay between Medicare and Medicaid, with Medicaid patients often facing greater socioeconomic disparity. Our model performance is described here. As you can see, in the derivation cohort on the left, our area under the receiver operating characteristic curve, or AUC, value was 0.86, and our value in the validation cohort was 0.85. For those of you who may be unfamiliar with AUC values, a value of 1.0 reflects perfect discrimination, while a value of 0.5 is unhelpful. Our values actually fit within the range of what is considered excellent discrimination. For Breyer scores to assess accuracy, a lower score indicates greater accuracy, and our Breyer scores were 0.099 in the derivation cohort and 0.064 in the validation cohort. They're not listed here. We actually did subgroup analyses in each of the surgical subtypes that we studied, and none of the AUC values fell below 0.78. To conclude, I'd like to discuss a couple of implications of our study. First, our risk instrument can facilitate perioperative decision-making by framing goals of care in terms of patient-centered risk. It may be useful for those at high risk to appoint healthcare surrogates or thoughtfully address code status. For some patients, the high risk of not being able to return home after surgery may dissuade them from undergoing surgery altogether, and instead they may choose more palliative options. For patients with comorbidities which may be optimized, the preoperative period may be a time to do that. And lastly, in this world of limited resources, we hope that our score can help identify not only the patients who need surgery, but the patients who will derive the greatest benefit from it. Thank you. And finally, I would be remiss if I didn't thank my mentor, Dr. Matthias Eicherman, and this team of collaborators without whom none of this work would have been possible. Thank you.
And any questions?
It's really nice work. My question is more for discharge to a non-home location. How important is this becoming at a national or payer or quality level? Like, you definitely hear about readmissions, length of stay, and I think it's a really important outcome. But where do you see it in the framework?
It's actually gaining a lot of national attention, particularly in terms of the Medicare and Medipac in terms of governmental organizations, there's actually been a call from Congress to look into the amount of money that we're spending in terms of post-acute care. And so what we hope is that our score, and obviously other models that have been described, can kind of help garner or at least understand who's going to be at risk for having these prolonged post-acute care stays, and hopefully lead to allocating those resources in a more effective and efficient manner.
I'd just like to add, I think that there's one other thing to take into consideration, in particular when we're talking about patient-centered care. Old people really do not like to go to care facilities. They really want to go home. And so in addition to the fiscal costs, I think there's probably some emotional cost, and it probably needs to be included as a part of their medical decision-making.
Absolutely. It's a great point.
Terrific. Thank you very much. Okay. I'm going to invite Dr. Shankar up to present comparative evaluations of acetaminophen administration strategies in preventing delirium after cardiac surgery. And she's from Beth Israel Deaconess as well in Boston.
Thank you. Good morning, everyone. My name is Pooja. I'm a CA1 resident from Beth Israel Deaconess. Today I'll be talking about a comparative evaluation of acetaminophen strategies in patients undergoing cardiac surgery. We looked at 2 RCTs, and we do have disclosures from both. The first one being the DEX-ACET trial, which was funded by Mallinckrodt Pharmaceuticals, and our second trial, which was supported by the FAIR grant, as well as the Chief Academic Officer Pilot Award from BI. So coming to the learning objectives and aims of our analysis, the objective really was to identify the effect of IV acetaminophen on postoperative delirium, and more importantly, to determine the optimal duration of administration of this drug on the incidence of delirium, and really just understanding the role of scheduled prophylactic administration. We aim to compare the effectiveness of IV acetaminophen, placebo, and standard of care in preventing postoperative delirium amongst elderly patients undergoing cardiac surgery. So why is this important? As you all know, postoperative delirium is a common complication after cardiac surgery with really detrimental and devastating consequences in the postoperative period. And we know that intense postoperative pain and the subsequent treatment with opioids has been proposed as a strong precipitating factor. While there have been numerous pharmacological interventions that have been studied in this regard, none have been shown to be effective to prevent postoperative delirium. So we had 2 RCTs that were conducted at our institution. The first one demonstrated a significant reduction in the incidence of postoperative delirium with intravenous acetaminophen compared to placebo in patients undergoing cardiac surgery. And the second one was an RCT that was conducted in a similar patient population in which we looked at varying levels of oxygen concentration that were administered intraoperatively. And in these patients, they received our standard of care for analgesia. So coming to our methods, the data for this analysis was pooled, like I said, from these 2 RCTs, as you can see in the table to break it down. RCT 1 looked at 120 patients over the age of 60 who were having CABG or CABG and valve surgeries. And they were randomized to receive postoperative analgesia with IV acetaminophen or placebo. And in our second RCT, we had 100 patients who were over the age of 65, and they were randomized to receive an FiO2 of 100 or 35%. It's important to note in the second RCT, we had no statistical association between the study groups. So to simplify this in terms of methods, basically we're looking at acetaminophen usage in the first 48 hours postoperatively, and we divided our patients into 3 groups. The first group received 8 scheduled doses every 6 hours. The second group was our placebo group that received no IV acetaminophen. And our third group is the group that received our current institutional standard of care, which averages out to be about 4 doses. So we're really looking at patients who received 8 doses, 0 doses, and 4 doses of IV acetaminophen. Our primary outcome was, of course, the incidence of postoperative delirium. Secondary outcomes included severity, intubation time, ICU, and hospital length of stay. Coming to our results, so as you see at the top, the acetaminophen group had a significantly lower incidence of in-hospital delirium at 10% when compared to the standard of care group and placebo at 31 and 28%. And what's interesting there is that the standard of care group and the placebo group are comparable in their incidences at 31 and 28, which kind of leads to the effect that 0 and 4 are kind of the same. And we also saw that the ICU length of stay was decreased in patients who received 8 doses of IV acetaminophen at 29 hours versus standard of care and placebo at 36 and 46 hours, respectively. So what we take from this is that some key points to note here is one, that it's scheduled administration of IV acetaminophen every 6 hours for the first 48 hours showed a significant decrease in the incidence of postoperative delirium as well as the ICU length of stay compared to placebo and our institution's current standard of care. These results are helpful in helping us choose an appropriate regimen that could prevent postoperative delirium, and I'm happy to say that our first RCT that was looking at 8 doses versus placebo is now moving on to be a multi-center trial. Thank you.
Did the standard of care group, did any of them receive acetaminophen?
They received 4 doses of
Yeah,
IV acetaminophen in the first 48 hours.
Hi, Vic Duval, UCLA. Thank you for that presentation. It's fascinating. So I think more than even pain, it's been shown that inflammation is a major contributing factor to postoperative delirium, and acetaminophen has anti-inflammatory properties.
Exactly.
How much do you think that anti-inflammatory properties contribute to your results versus just reduction in pain medications?
That's a great question. We, first of all, of course, chose IV acetaminophen as our drug to study because of that property. We are looking at a biomarker analysis, which is still pending or in process, but that's something that we're looking into.
Thank you.
Thanks.
Do you get any questions about the cost of intravenous acetaminophen versus the administration of PO administration when you're thinking about this with regards to the cost at your institution?
Pretty much all the time. That's the first question, and it's a good question to ask. The reason that we chose IV acetaminophen, one was because of the bioavailability. There have been numerous studies that show a reduced bioavailability in the immediate postoperative period, especially in the first 2 days after surgery, which is also when the incidence of delirium is the highest. So that's one reason. And the second thing is it would be great if there could be a study that looked at the PO administration of acetaminophen. It's just not been done yet.
Thank you.
All right,
All right,
thank you. Oh, one more over there.
Community practitioner, so I have a different take than obviously the academics do. 5 years ago, again, last time I came to this conference, we all started giving IV acetaminophen. Now all the studies are being published that the PO stuff is just as good as the IV stuff in most surgeries. But often forgotten is the rectal route, which costs 5 cents instead of $15. Does cost a little bit more than the PO route, which is 2 cents. But in our pediatric patients, it works fine. In elderly patients, hey, it might even help the bowel movements.
That would be something to investigate.
Okay.
Thank you.
Thank you very much. Okay, our next speaker is Dr. Zhan from Tongji Hospital in China. He'll be speaking about anesthesia and surgery induce cognitive dysfunction in elderly male mice, the role of gut microbiota. Is
Can you
Dr.
make sure that that set is up? Is that individual here?
Is Dr. Zahn here? No? Okay, well, I think then we'll move to abstract 8, which is closed-loop intravenous anesthesia and postoperative cognitive dysfunction after non-cardiac surgery by Dr. Besch from France.
Hello, everybody. I'm not the Dr. Besch, I'm Nicolas Mar. It's me who made the presentation. So,
Can we please have the presentation?
Just let us hunt up your,
intravenous anesthesia, please. Is this yours?
yeah, it's fine.
Okay.
Thank you.
But I'm not the Dr. Besch, though. So, Nicolas Mar, I work at University Hospital of Besançon in France. I'm going to present the result of the POCD-ELA trial. I have no conflict of interest to disclose. We can pass to the next again. So POCD are defined by a persistent delay in neurocognitive recovery. It's a common complication of anesthesia in elderly patients, about 25% after a minor non-cardiac surgery. It's a complication associated with poor outcomes. And if physiopathology still remains unclear, anesthesia may play a role in the genesis of DNR. Chan et al. In the CODA study describes that BIS-guide anesthesia may decrease the rate of DNR, and Hu et al. In 2018 described that a low BIS target may increase the rate of DNR. We can pass to the next. Closed-loop controller allows the automatic titration of both propofol and remifentanil, guided by the BIS. The automatic titration of anesthetic agents has been shown to increase the time spent within the BIS target range and decrease both number and length of episodes of an excessive depth of anesthesia. We can pass to the next. Our hypothesis was that closed-loop target control infusion of propofol and remifentanil could lower the rate of DNR by reducing the risk of an excessive depth of anesthesia. Next, please. POCD-ELA was a single-center, single-blind, randomized controlled trial conducted between 2013 and 2018. It's also a sub-study of the ELA study. You can see our inclusion and exclusion criteria. We notably exclude patients with a medical history of neurological or psychiatric disorder. We exclude patients with a current psychoactive substance using, like benzodiazepine or neuroleptic agents. According to the ELA study protocol, the randomization was stratified by age and cancer, and the allocation ratio was between closed-loop and manual groups was 2:1. Next, please. Our anesthesia protocol, in our anesthesia protocol, we only use total intravenous anesthesia with no ketamine infusion. We made BIS-guide anesthesia for all patients with the same target range, 40 to 60. In the closed-loop group, the administration of intravenous anesthetic was performed by the computer, and in the manual group, it was performed by the anesthesiologist. Except this administration, the anesthesia was at the discretion of the anesthesiologist. Next, please. Our primary endpoint was the rate of DNR within the 72 hours after surgery. We define DNR by a decrease about 20% on at least 3 scores. The neurocognitive assessment were performed in good conditions, meaning in a quiet room with non-pain patients with a trained neuropsychologist. We performed the baseline neurocognitive assessment the day before surgery and the other tests within the 72 hours after surgery. Both patients and neuropsychologists were blinded to the randomization group. You can see the test we performed. We performed a global efficiency test like MMSE or MATIS test. We performed executive functioning test, memory test, and attention test. Next, please. We include and analyzed 204 patients. There was no difference in the baseline characteristic between the patients. The surgical procedure was an orthopedic surgery in 30% of the case and an urological or gynecological surgery in 60% of the case. About our anesthetic management, the duration of anesthesia was about 200 minutes in the two groups. There was 70% of the patients who had regional anesthesia, more general anesthesia. There was no difference between the group for the use of vasoactive agents or the need of red blood cell transfusions. In the closed loop group, the dose of propofol was significantly lower, while the dose of remifentanil was significantly higher than in the manual group. And if you have a look on the BIS, in the closed loop group, the BIS was more closely respected than in the manual group. But we failed to find a significantly difference in the rate of DNR. The rate of DNR was 30% in the closed loop group and 16% in the manual group. Next, please. If you have a look on each test, next, please, you can see that there was no difference for each test between the group. Next, please. So closed loop anesthesia failed to find a significantly difference in the rate of DNR. There is two ways to explain this result. First, we have a low rate of DNR in our control group. There is, it's possible that it may decrease the power of our study. There is several ways to explain that. First, we use total intravenous anesthesia. It's a difference between our study and the other study. It may decrease the rate of DNR. We performed BIS guide anesthesia for all patients that surely decreased the rate of DNR for our patients. Moreover, because the time spent within the BIS target range was high in our control group. The other way to explain this result is because DNR are not only related to the depth of anesthesia, inflammation or other mechanisms are implicated in the genesis of DNR. And maybe the effect of this mechanism is more important than the benefic effect of a more closely respect BIS in our study. Next, please. So we can say that closed loop compared to manually driven BIS guide total intravenous anesthesia provided a significant reduction in episode of an excessive depth of anesthesia on decreasing intraoperative propofol requirements, but failed to reduce the incidence of DNR after an elective minor non-cardiac surgery. And the hypothesis of an improvement of postoperative cognitive recovery by a global approach of care covering preoperative, intraoperative, and postoperative periods should be investigated in further study. Thank you very much.
So your prevalence of postoperative cognitive deficits was reasonably low based upon what you showed. Did you do a power analysis to determine how many patients you would need to enroll in a larger study to see whether or not that difference was in fact real versus an artifact?
Before the study, we do a power analysis, but our hypothesis was that we will have 25% of postoperative cognitive dysfunction, like Moller et al. In ESP-OCD1. But there is such difference between his study and our study because we make BIS guide anesthesia, total intravenous anesthesia. We performed anesthesia with regional anesthesia, more general anesthesia that should decrease the need of pain drugs after surgery. So we don't make the same anesthesia as him, so maybe it's we failed power because of that, because our hypothesis was maybe good when we start the study, but in reality, not so good. Sorry for my English.
Dr. Rowe.
So I agree that your present study was damned by your own success, but if you are doing future studies, I would encourage you to have measurement points beyond more than a couple of days after surgery, because the cognitive dysfunction that we're worried about is not immediately after surgery, but months after.
Yeah,
and
sure.
until we know that that's going to be affected by an intraoperative or perioperative change, it's not really helpful, in my opinion.
Thank you.
Dr. Berger.
Yeah, hi, thank you for that talk. And I apologize for my voice here. The question I have is, I think you defined DNCR as a 20% drop in 3 or more tests. Is that correct?
Yeah.
Yeah. So I think in the new nomenclature for perioperative neurocognitive disorders, there's not a specific test threshold for DNCR, but for NCD, which is sort of the new equivalent of POCD, neurocognitive disorder postoperative, the threshold is a 1 SD drop for mild and a 2 SD drop or greater for major. I'm just wondering if you analyzed your data using those thresholds and whether you saw anything different.
Thank you.
He's asking whether or not you used those alternative thresholds.
Sorry, I don't understand.
Did you analyze your data in any other way?
No.
Okay, great. Thank you, because my French is not good enough to explain that in French.
Sorry for that.
Thank you.
Thank you very much. Thank you. Okay, well, the next abstract is the Sandman study, sleep apnea, neuroinflammation, and cognitive dysfunction manifesting after non-cardiac surgery. And I'd like to invite, is it Thomas Bunning who's here today from Duke to present that? Okay.
Thank you. Good afternoon. My name's, or morning, I guess it is now still. My name's Thomas Bunning. I'm actually a fourth-year medical student at Duke. I've had the privilege over the last couple of years of working in a lab with Dr. Miles Berger and Mike Deviney on a lot of the same research that we've been hearing about. And one thing that we specifically look at is neuroinflammation and how that might affect these disorders after surgery. Here to talk today about one of our actively enrolling studies looking at the relationship of sleep apnea with neuroinflammation and postoperative delirium and neurocognitive dysfunction. We can go to the next. So Dr. Brown and a lot of the speakers before me have kind of characterized the epidemiology and contextualized these issues in front of me. But suffice it to say, these relatively short-term complications have long-term consequences that people in this room appreciate better than anyone. We can go to the next. And actually one more. So I mentioned that one of the potential risk factors that we look at in this study is sleep apnea. One more, please. So we know that several small studies have shown that sleep apnea is associated with an increased risk of postoperative delirium. What you're looking at here is a graph of an apnea-hypopnea index, or an indicator of the severity of sleep apnea, against the incidence of postoperative delirium. And what we see here is patients with an AHI of greater than 19, indicating moderate or severe sleep apnea, are much more likely to develop postoperative delirium in the days after surgery than patients with absent or mild sleep apnea. Now, but what about longer-term cognition? This hasn't been studied as well in post-surgical populations, but this graph is from a non-surgical study looking at dementia incidence over time and following and realizing that patients that have sleep apnea are more likely to develop dementia over time. What we also see is more likely to develop mild cognitive impairment, and patients with sleep apnea and dementia also have not shown here, have a worsening cognitive or steeper cognitive decline. So what is it about sleep apnea that's causing these relationships to be the case? We can just next to remove those boxes, please. So it's most likely multifactorial, lots of things going on, and like I said, we try to focus on an element here and there. The things that we look at are the direct consequences of sleep apnea, the sleep disruption that we see, we can demonstrate with EEG changes during sleep studies. We also know that sleep apnea is associated with impairments in synaptic plasticity and brain metabolism, and there's evidence that sleep apnea is also associated with vasoreactivity and sympathetic surges causing sympathovagal imbalance. But also patients with sleep apnea demonstrate peripheral inflammation, and this inflammation throughout the body that these patients have might have an effect on the CSF and directly on the brain. So why do we think this? Why do we think that neuroinflammation might be happening in patients with sleep apnea? What you look at here is a marker of peripheral inflammation. This is serum interleukin-8 against that same apnea-hypopnea index, that severity of sleep apnea. And we see that patients with higher apnea-hypopnea indices or more severe sleep apnea also have higher concentrations of serum interleukin-8. We also know that patients with sleep apnea have MRI findings consistent with neuroinflammation shown on the right, gray matter losses that are actually improved by treating the sleep apnea with CPAP. So this evidence suggests that these things might be linked, but we don't have a lot of studies looking directly at this issue. So now we turn our attention to the Sandman study, where we ask two main questions. The first is sleep apnea associated with postoperative delirium and postoperative cognitive dysfunction? And the second is sleep apnea associated with neuroinflammation? So the way we do this, Sandman is a sub-study of the parent Intuit study, also at Duke, with Dr. Miles Berger, looking at neuroinflammation in patients after surgery. And how this looks is patients are scheduled for non-cardiac, non-neurosurgery, and if patients agree to participate with us, they come see us a few days before surgery. They have a very extensive neurocognitive battery, similar to what speakers before me have discussed. In addition to that neurocognitive battery, patients in the Sandman study get an Epworth Sleepiness Scale. We also give them a home sleep apnea testing device to take home. They wear that in the nights preceding surgery and then bring it back to us on the day of surgery. On that same day of surgery, patients get baseline CSF and blood samples before induction, and then 24 hours after surgery, they have repeat CSF and blood samples. I'll take a brief aside here to say that these are not LPs that these patients would be getting already clinically. These are LPs that these patients have agreed to for the purposes of this research. In addition to that CSF and blood, our patients also get delirium screening with a 3D cam twice daily on postoperative days 1 through 5. And then after patients go home at 6 weeks, they'll come back to do another neurocognitive testing battery, as well as redo the sleepiness scales and another round of CSF and blood samples. So I mentioned this home sleep apnea testing device that goes home with our patients. This is what the device looks like. It's a combination of a strap that's worn around the chest and a cannula that's worn in the nose. Our patients tolerate this device pretty well. They say it doesn't interfere with their sleep very much, and it actually gives us a lot of useful information. So this is what a sleep study with that device that patient wears shows us. In a normal patient, this is from data from one of our patients that didn't have sleep apnea. You see on the top, good airflow indicating regular breathing, the chest belt showing good chest wall motion, and the heart rate and pulse ox remaining at baseline and constant rates. However, in a patient with severe apnea, this is what an apneic episode looks like. You can see that despite having adequate chest wall motion, there's no airflow indicating an obstructive pattern. And as that air isn't flowing and that patient isn't oxygenating, their heart rate and oxygenation decrease. When they have the arousal event, you see a big sporadic jerking awake in both the nasal cannula and the chest belt, and the heart rate and pulse ox return to baseline. So I mentioned that Sandman is a sub-study of the parent Intuit study at Duke. I mentioned we're actively enrolling. This is where we're at so far. The Intuit study, is enrolling 200 patients over 5 years. Sandman will likely land anywhere between 80 and 100. We do include everybody who is, like I mentioned the surgical types earlier, we include everybody in the Intuit study unless they're being actively treated for sleep apnea. So far, between patients that have completed all these parts with us, as you see, we have 51 so far that have completed sleep apnea testing and had good data that we've been able to analyze. So this is our distribution of apnea-hypopnea indices in the patients that we've analyzed for sleep apnea so far. This is a distribution plot, but we'll actually go one more. And here you see the same data numerically. Now, one thing that we were initially surprised by this, you see 39% of our patients were negative for sleep apnea. That means that the majority, over 60%, tested positive for some degree. Now, these aren't patients that we necessarily expected to have sleep apnea that reported symptoms and wanted to come in for testing. These are community-dwelling older adults, and we were surprised initially that this high of a percentage of patients had sleep apnea. That said, these numbers are actually relatively consistent with larger population-based studies of untreated and undiagnosed sleep apnea in community-dwelling older adults. And one other thing I'd like to focus on this slide is that, like I said, these patients aren't seeking evaluation or seeking treatment, but because we've identified undiagnosed sleep apnea in this many patients, all of these patients who tested positive in any of the 3 positive categories have been referred to sleep medicine for further evaluation and treatment. So this study would not be possible without a FAIR grant that's really bolstered the Sandman part of this with Mike Deviney, as well as our lab PI, Dr. Miles Berger at Duke, and his K76. Of course, a lot of people go in making this study work, our clinical or our surgical and anesthesia colleagues, and of course our patients. for being willing to undergo a lot of tests and many LPs, all for the sake of research. One more, please. And
I think it's actually.
it's there. On a more personal note, Dr. Mike Deviney, who runs the Sandman part of this, Miles Berger, who runs the Intuit side. Thank you, Dr. Andrew Spector, who helps us read these sleep studies and get these patients referred for treatment, and Joseph Matthew, our department chair, for mentorship as well. Thank you very much.
That's a lot of patients with obstructive sleep apnea.
Yeah.
Is it a geriatric syndrome now?
So like I said, looked more into that after realizing how high that incidence was, because it was higher than we thought it was, and I'm happy to redirect to it. But there was a population study and a meta-analysis looking at somewhere between 5,000 and 6,000 patients in the same demographic that we were looking at, and they landed right around 51%. Now, most of these are mild, so these patients aren't having, the more severe, the worse the symptoms are. But yeah, the fact that they tested positive, that is a lot of patients.
Dr. Rook.
Actually, I think it is becoming recognized that sleep apnea is endemic in the older population. But I realize you don't have any of the inflammatory marker data yet.
Yes, sir.
And also your study patients were all with undiagnosed sleep apnea. So we're all familiar with the treatment of sleep apnea and how CPAP will keep people from having deoxygenation events, but it would be very interesting to know if it also prevents the inflammatory response
Absolutely.
to sleep apnea.
Yeah, so the downside of the timeline that we have is our patients wouldn't actually have their sleep study read until after they have surgery. Like I said, all our patients are referred, if they test positive, are referred for treatment. And one of the things we're looking at is the Intuit study actually has patients back for further LPs and blood, as well as neurocognitive testing at the 1-year mark. So if patients start testing, it's still post-operative, but if patients start testing in the first month or two after surgery, does that affect any of the 1-year data? Of course, we'd like to treat it before surgery and remove that, but
Thank you.
thank you very much.
Do we have Dr. Kotake here from Tokyo, Japan, to talk about influence of age on the onset and duration of neuromuscular blockade of rocuronium, comparing septuagenarians and octogenarians?
Thank you for your introduction. I got several conflict interests. And the learning objective of this study is, among the neuromuscular blocker has different effects in the elderly patient, but the difference between the elderly patients has not been clearly demonstrated. So recently, the onset of action of the rocuronium after intubation dose is significantly longer in patients over 70 years comparing to the more younger patients. And also the duration of the action and longer interval between the Sugammadex administration to the adequate recovery of the neuromuscular transmission has been longer comparing to the younger patients. However, we have hypothesized that there would be a difference in response to the rocuronium between patients in the 80s and in their 70s. So we compare the time to onset of action and initial spontaneous recovery from the intubation dose and Sugammadex associated recovery at the end of the surgery between the 80s and 70s. We used our existing data to study this hypothesis. The original study involves 60 patients who undergo elective laparoscopic colorectal surgery who was anesthetized, total intravenous anesthesia, and thoracic epidural block. Intubation dose of the rocuronium is 0.9 milligram per kilogram, and neuromuscular transmission is monitored with accelerometric monitor. And the neuromuscular transmission, neuromuscular blockade is maintained to maintain PTC less than 5 during the surgery. At the completion of the surgery, neuromuscular blockade is monitored at the abductus pollicis and antagonized with the recommended dose of schematics. So the primary outcome of this comparison is the interval between administration of intubation dose of Roculine and achievement of complete break. Secondary outcome is the interval between the intubation dose and return the first PTC, and also the number of patients with deep moderate neuromuscular blockade at the end of the surgery, and also the interval between the administration of schematics and full neuromuscular recovery. So this table shows demographic data between the 70s and 80s. 18 patients in the 70s and 17 patients in the 80s are analyzed. There is females are more involved in the 80s, and patients are slightly underweight in the 80s, but otherwise there is not much significant difference. Okay, this table shows the outcomes of the primary and secondary outcomes. Okay, so the first row, the onset of neuromuscular blockade is significantly prolonged in the patient in the 80s. And the second row, the interval between the intubation dose and the reappearance of the first PTC is not significantly different, but at the end of the surgery, more patients in the 80s remained in the deep phase of the neuromuscular blockade. And the last row, the interval between the schematics administration and complete recovery of the neuromuscular transmission is demonstrated, and also the patient in the 80s have the more longer interval between for the recovery. So there is some there are some available data between the younger and elderly patients, and these previous studies suggest that the possible mechanism of delayed onset is low cardiac output and reduced muscular blood flow. Also, slow equilibrium to biophase is also suggested. And the reason why the recovery of the schematic assist recovery is also the low cardiac output is suggested. So the conclusion of this study, in this study, the time to onset reduction of Roculine and schematics assisted recovery were slower in patients in the 80s than in those in the 70s. However, there is no significant difference in time to recovery of PTC after intubation dose between the two age groups. Thank you.
I'm wondering whether or not you corrected for gender, because in one group you had significantly more males, and in the other group significantly more females.
Yeah, I totally agree with that. Probably the age as well as the gender may affect this result, and I look after these corrections.
So how would you differentiate between whether or not it was age versus gender?
Okay. Yeah, probably. Right now we analyze age-based, but gender also has to be considered for further analysis.
Any other questions? Alex. How are you?
Sorry. Just an editorial comment. The issue of slow flow in the elderly, I have serious problems with. The changes in cardiac output with aging are based more on the change in body composition than actual blood flow to individual organs. So I really doubt the drug is getting there any more slowly in an older person than a young person, other than maybe the venous flow to the heart in the first place. So I think we probably have to look further for explanations for why these time delays occur.
Okay, thank you.
Thank you.
Thank you.
Thank you very much. And then the next abstract is increased plasma alpha-synuclein in brain-derived exosomes is associated with postoperative delirium. And that's going to be presented by Dr. Yuan from Beijing, China.
Good morning, everyone. My name is Yi Yuan. I'm from Jishuitan Hospital, Beijing, China. It has been a great honor to represent our group here. Well, I've no disclosures. Well, what I'm going to talk is back to postoperative delirium. Well, the POD, the incidence of POD in elderly patients with hip fracture is really high. And the main pathology is actually the synapse dysfunction. So as you can see here, the ARF-SYN is actually a synaptic regulation protein. And normally, it's in a monomer form and located in the presynaptic membrane. But however, when adverse stimulation occurs, the monomers could transfer toxic polymers, like what you can see on the right side of the screen. And the polymers could destroy the network, the neuron network, and leading to what we call ARF-SYN-related cognitive disorders. Next. Well, one of the typical example for ARF-SYN-related cognitive disorder is Parkinson's disease. Well, actually, there are several similar symptoms between this group and disease and POD. However, little is known by now, the exact association between them. One clinical study showed the ARF-SYN pathology in the stomach was associated with POD after gastrectomy. Well, more recently, the same research group reported a significant correlation between POD and Parkinson's disease-related non-motor symptoms. This evidence actually implies that POD might be a preclinical stage of ARF-SYN-related cognitive disorders. And besides, there was one animal study showed the ARF-SYN level in the cortex of the mice has increased after surgery. Well, based on this, next. Thank you. We posed our question. Is the change in ARF-SYN associated with POD in elderly patients with hip fracture? Well, the diagram on the left side is our hypothesis framework. Well, the problem is how to measure it. Actually, the ARF-SYN is not restricted to the brain. We can detect it in many peripheral tissues. For example, in the plasma, the ARF-SYN it can be in a free form or can be associated with exosome. Exosome is showing on the right side of the screen. This little particle actually plays a very important role in intracellular communications. And it was reported that the plasma exosomal ARF-SYN is likely brain-derived and was found to be increased in patients with Parkinson's disease. Well, therefore, following the same strategy of the previous study, we decided to measure the ARF-SYN in the plasma exosome. Well, next, please. we conducted a 1.1 matched case and control study. We screened 263 patients with hip fracture, and 61 were excluded. In particular, we excluded those who have received blood transfusion perioperatively. Well, within all the included patients, 17 was diagnosed with POD, and 17 non-POD controls were matched according to the following 5 factors. Next, please. All the data line bases were collected 1 day before the surgery, and on the operating day, both general and spinal anesthesia were accepted. We ensure a very good pain control by the use of both ultrasound feature iliac blocks and the PCA device. All the patients were followed up for 2 days, twice a day, by a well-trained geriatrician. Well, the delirium was diagnosed using COM, and the severity of delirium was measured by MDAS. The cognitive function after discharge was performed by telephone using TICS by the same geriatrician. Venous blood sample were collected pre-op and post-op. Next, please. To purifying the exosome from plasma. Next, please. Next. Continue. Yes. We choose the immunoaffinity method in order to maximize the content of the exosome. And besides, we also determined the plasma inflammatory cytokines, interleukin-1 beta, interleukin-6, and TNF-alpha. Next, please. Well, the incidence of POD is 8.4%. And the figure on the left side shows the concentration of ARFSIN. Well, from A and B, we can tell that either in pre-op or post-op, actually there is no difference between groups. Similarly, in figure C and D, we can tell in either group, the alpha-synuclein level has no difference between pre-op and post-op. However, figure E showed the change in ARFSIN from pre-op to post-op has significantly higher in POD groups. And this change is actually positively correlated to MDAS, which implies that the greater it changed, the severe the POD presented. And figures on the other side shows the inflammatory cytokines. The first line shows the pre-op levels and no difference between group for all the 3 cytokines we measured. And the second line is post-op levels. We can find that the interleukin-1 beta and interleukin-6 was much higher in POD groups. And besides, the POD groups has a higher elevation in interleukin-6. And this change in interleukin-6 is actually positively correlated to the change in ARFSIN. Next, please. Well, TICS represent the cognitive function, as I mentioned before. So the higher, the better. We found that the TICS on post-op day 30 is higher compared to the TICS on post-op day 7. And there was a negative correlation between the change in interleukin-6 and the TICS on both day 7 and day 30. However, this negative correlation between the change in ARFSIN and TICS was only showed on post-op day 30. Next. Our results reveal that it is the change in ARFSIN that really matters, no matter its increase or decrease. We speculate that after the fracture, the ARFSIN within the neuron started to change in both quantity and quality. The increased ARFSIN could further spill into the intracellular space. And that is where we capture the protein and measure it in this study. However, it was hypothesized that the ARFSIN in this area could further spread the pathology by entering into another urine, causing more damage. If that happened, when we measured in the intracellular space, actually the arsenic could drop, but the brain damage is getting worse. The problem is you don't get to know the exact timing for this spill and the spread. Therefore, it is the change amount instead of the change direction that represent the potential injury of the brain. Next. We also found that a positive correlation between the change in interleukin-6 and the change in arsenic, which represent a mutual regulation between the neuroinflammation and the arsenic pathology. Actually, our group has been working on the perioperative neuron disorder, this PND for a long time. But at first, we focused on the neuron inflammation. And this time, we further explore the synaptic regulation protein arsenic and its potential contribution to POD. I think, yeah, time is limited. Basically, we've answered the question we posed in the first time, but there are still many limitations in our study. I don't think I have enough time to go to the detail, but I believe that there are many, many further investigations out there waiting for us. So thank you very much.
So I have a question for you.
Yes.
You used exosomes, and they were in the plasma. Did you do anything to determine whether or not those exosomes were of neuronal origin?
Well, actually, we based on the protocol published by the previous study. I think we used a detailed method step by step, and we purifying them from the plasma, and
So this could have come from any region of the body, not necessarily from the brain.
Well, it was reported that the plasma exosomal arsenic is highly related to the brain. It's more likely the brain derived. So.
In your exclusion criteria for this study, were patients that had preoperative known Parkinson's disease and other neurodegenerative disorders such as Alzheimer's, were they included in the study, or were all of these patients that didn't have any of that?
I didn't go detail to the excluded criteria. We didn't include any any patients with diagnosed Parkinson's disease because it's typically, arsenic-related cognitive disorder.
Thank you.
Thank you.
Thank you. Yep.
We would like to thank all of the presenters for wonderful presentations today, and we would like to encourage you to submit your manuscripts to anesthesiology. Any further questions? With that, I think we'd like to end this session. Thank you.